Well, good morning and welcome to the third workshop in our COVID Recovery and Resiliency webinar series. This webinar series is hosted by the Delta Center for Economic Development, Arkansas Economic Development Institute, and the Arkansas Association of Development Organizations. I am Andrea Allen, Executive Director of the Delta Center for Economic Development at Arkansas State University. A healthcare workforce shortage in our country has long been predicted, even prior to COVID-19. This and other factors, such as the accelerated rate of rural hospital closures and the increase of chronic health problems among rural populations, had placed many rural American communities in a precarious position well over a decade ago. The pandemic has only amplified these problems and has highlighted the urgency of finding solutions to these challenges. We have a very distinguished lineup of presenters for today's workshop who are all working to find such solutions at the local, state, regional, and national level. Our topics will include COVID-19, impacts on mental health in Arkansas, and the AR Connect program, healthcare workforce resilience, health professionals thinking outside of the hospital, an overview of the Innovative Readiness Training Program, and telehealth solutions. But now let's listen as Governor Asa Hutchinson welcomes everyone to today's workshop.
Good morning. I'm Governor Asa Hutchinson. Welcome to the Arkansas Recovery and Resiliency Workshop, which will add to your knowledge of new tools and resources as you prepare to lead in times of difficulty, such as what we've experienced during the pandemic. COVID-19 has touched every aspect of our lives. We have lost loved ones and friends. We've changed the way we educate our children and how we gather for worship and other community activities. Many have lost income or lost a job. In the midst of this, Arkansans have eagerly and unselfishly stood up to help their neighbors. And this is the spirit that will see us through other tough seasons. The Arkansas State University Delta Center for Economic Development, the Arkansas Economic Development Institute at UALR, and the state's planning and development districts are hosting these workshops around the state with the support of the U.S. Department of Commerce Economic Development Administration. These workshops teach community leaders and business leaders to implement new strategies for resiliency and recovery. Thank you for taking the time to attend and for your service to Arkansas.
And thank you, Governor Hutchinson. A few quick reminders for today. Of course, the Zoom link will be open and active all day. You may join and rejoin as needed. Your microphones will be on mute, but feel free to type any questions into the chat box. Also, for the best quality viewing of today's workshop, please set your Zoom view to standard view. This morning's sessions will end around 11:45. We'll restart right at 1 with the session on healthcare workforce resilience, and we'll end today at 4. Also, we're recording today's workshop as well as others in our webinar series, and we will start having them available on the Delta Center's website next week. Our first presentation today is COVID-19 Impacts on Mental Health in Arkansas and the AR Connect program by Dr. Teresa Hudson, Professor of Psychiatry and the Director of the Center for Health Services Research at the University of Arkansas for Medical Sciences, Psychiatric Research Institute. Dr. Hudson has conducted research about the delivery of and access to health services for more than 2 decades. Her past work examined access to safe, high-quality medications, disparities in access to behavioral health and substance use care, suicide prevention, and development and validation of quality indicators for treatment of persons with co-occurring mental health and substance use disorders. Recently, her work has expanded to development of nation and statewide programs for improving behavioral health and wellness. Thank you so much for being with us today, Dr. Hudson, and I'll go ahead and let you get started.
Good morning. Thank you. I'm just going to go ahead and share my screen. Let me see. Give me one moment here. I'm having some challenges with just Give me 1 minute, just bear with me and I'll be. Let's try this again. Share. Okay, I'm gonna have to start over. I apologize. I normally can do this, but sometimes I struggle. Okay, stop share. And start again. Share screen. I apologize. Give me just a second. I've
No,
got.
you're
I
fine.
completely closed the screen I wanted, and so I have to go back and open it again.
It happens to all of us.
And so, all right, let us try one more time. Now, are you looking at a screen that says COVID-19 impacts on mental health in Arkansas and the AR Connect program?
We are.
Excellent. I'm happy to hear it. Okay, so thank you all so much for inviting me to be here today. You have clearly an excellent set of presentations today, and I hope you will find this one useful. I am indeed very excited to share this information with you, although I really need to edit that bio because that whole 2 decades thing doesn't sound so good. I think I'll pull that out in the future. But at any rate, let me just tell you a little bit about what AR Connect is, and then we'll go from there. So AR Connect really is a federal state partnership that includes the U.S. Substance Abuse and Mental Health Services Administration. Then at the state level, it has the Arkansas Department of Human Services, Division of Aging, Adult and Behavioral Health Services, and the Office of the Drug Director, which is Kirk Lane, as you know, is the drug director, and Jennifer Schuler is the project director for the state. At the UAMS Psychiatric Research Institute, I'm the director of health services research, but also of the AR Connect program. I have a co-director, Dr. Chris Cargile, who's a psychiatrist, who also leads the UAMS Behavioral Health Service line. And then many of you probably know Dr. Rick Smith, who he says he retired. We'll see how that goes. Those of you who know him know that he retires. The next thing you know, he's back working. So we'll see how that goes. But at any rate, it's important that we bear in mind that this, I'm very proud of this program, but it exists because we have this excellent partnership. So today I'm going to give you a little bit of the stats about what we know about mental health and substance use during the COVID-19 pandemic, describe the goals of the AR Connect program, discuss how one goes about using AR Connect. We will also describe who we've served so far and what kind of clinical outcomes we've had so far. And then I hope to enlist you all to help out a little bit. So, and also, if I don't know how you're handling questions today, but I'm happy to take questions at any time or at the end, whatever works well.
I'll monitor the chat for you, and if people would like to place questions into the chat, I will let you know.
Okay, that sounds great. Okay, so unfortunately, I had difficulty finding statistics about rates of various mental health problems in Arkansas. So what I'm going to give you are pre-COVID and during COVID population weighted survey results across the US. So pre-COVID, the prevalence of depression in the US populations was about 7%. A recent survey that was weighted to the US population found a prevalence of 33%. So that's a pretty dramatic increase. For PTSD, post-traumatic stress disorder, the US population estimate before COVID was 6%, but post-COVID in that same survey was 24%. Insomnia is a pretty common problem in the US, certainly more problem than PTSD and depression. And pre-COVID was around 19% of the US population. A recent estimate is 27.6%, almost 30% of the US population is struggling to sleep. Going to anxiety, roughly 19% of the US population was struggling with anxiety problems prior to COVID. Now during COVID, that's gone up to 31, almost 32%. So you can see that the prevalence of mental health problems in the US is certainly dramatically increased during COVID. And then, you know, I don't know how many of you observed this, but one day especially when Arkansas was shut down, I was driving out of my house, which was unusual. I normally was at home, but I was driving and I went past a liquor store and all the businesses were shut down. It was when even the restaurants and fast food and everything was shut down. But the liquor store had a drive-through line that was backed up. People really took advantage of staying home to use alcohol. And so on the left here, what we have is some estimates of drinking habits in the US population in 2018 and 2020. And this blue box or bar is the average number of days people reported drinking per month. And then the kind of orange bar is average number of drinks in the last 30 days. The gray is the proportion of people, so the percent of people who report binge drinking, which for women is greater than 4 or more drinks on a single occasion. And for men, it's 5 or more drinks on a single occasion. And then extreme binge drinking was reported by 3.7% of the population, which for women is 8 drinks on an occasion, and for men is 10 drinks on an occasion. So that was pre-pandemic. In 2020, that was examined again. Drinks in the last 30 days were in 12.2 drinks were reported in the last 30 days. So almost 3 times the number of drinks reported. These are average number of drinks per week. The orange is drinks in the last 30 days. And you can see that too, more than doubled. So it went from 12 to 26.8. And then the proportion that report binge drinking in the last 30 days increased somewhat, 31.8 to 30.4. But then you can see that the extreme binge drinking, the ones that were drinking 8 for women or 10 drinks for men on an occasion, also doubled, 3.7 in 2018 to 7% in 2020. So although these are not Arkansas statistics, again, I couldn't locate a survey that really gave me information about Arkansas, but you can see that these had pretty substantial increases. And then recently you may have heard concerns about overdose deaths, particularly opioid related deaths during the pandemic. And literally this is data from the CDC. These are numbers of deaths. It's not a rate, it's annual overdose deaths in the US over the last 6 years. And you can see this blue line here are synthetic opioids. So those are the fentanyl overdoses, frankly. Those are the, and then also one of the big, fentanyl is now the big offender, but in 15 and 16, hydrocodone was one of the major issues, and oxycodone. So those are opioid deaths, or excuse me, those are the synthetic opioid deaths. The orange line are all opioid deaths, and the purple line is overdose deaths for any kind of overdose. So as you can see, from 18 to 19, it was starting to flatten a little bit. In fact, from 17 to 18, overdoses went down overall, although they continued to climb for synthetic opioids. But this is where we were doing a lot of work, decreased prescribing opioids, prescription opioids. So it was looking pretty good right in here. And then from 2019 to 20, we've had this steep increase in overdoses. So this all suggests an acute need for mental health and substance use care for the population. That's the reason SAMHSA issued the opportunity for states and others to apply for this funding. So UAMS, with the Office of the Drug Director, applied and created AR Connect. And so what is AR Connect exactly? Well, it's a virtual clinic to provide urgent care for mental health and substance use problems. The idea is to really help Arkansans cope with urgent problems, sort of like when you go to urgent care because you have the sniffles, or your stomach's all upset and you can't deal with it or whatever. It's the same principle. It's trying to get care taken care of right away. And I already mentioned the funding sources. But one thing to note is individuals who use this service have zero out-of-pocket expense. So those that have insurance do not pay a copay. Those that do not have insurance, it's not an issue. However, we will try to help sign them up for insurance if they are eligible. So we try to not only take care of the urgent need, but help people have a way to care for needs in the future. And we'll talk a little more about that shortly. So that brings me to the really great part. Who can use these services? And the answer is whoever's in Arkansas. And that you may have seen the information on the news recently, where we our clinical director was there, Tony Boaz, and he pointed out that in fact, if someone is displaced to Arkansas from one of the hurricanes, while they're residing in Arkansas, they can call for help, and AR Connect will see them. So I just want to encourage you, if you have someone staying with you for an extended period of time and they need some help, AR Connect can help them. Okay, so that begs the question then of how does AR Connect work? And I know this is kind of a busy slide, but I thought it was more interesting than listening to me or than reading it if I wrote it out. All of the pictures you see here are clip art that I pulled off the internet that was free and available. So I really don't know who anyone is. And so just to be clear. So it starts with someone calling AR Connect. And we have a call center that is open 24/7. So you can call the call center and request care 24/7. At the time you request the care, a nurse will answer that call center phone and make sure you're not in an emergent situation. If you are standing with a gun to your head, we will send an ambulance and encourage you to go to the emergency department, but we can't really do a lot other than get emergency services to you. However, if it's urgent and not emergent, we will take some basic contact information and you will see an intake therapist within usually 1 business day. So the call center has a whole list of the available times and can slot people in right then. And normally we have somebody available within a single business day. If you call late Friday night, then you probably wouldn't be seen till Monday. That's, and the same for late Saturday night. You still wouldn't be seen, or Sunday, you wouldn't be seen until Monday. We would do some intake and begin some initial problem solving with what's most urgent, what do you need help with? So that visit takes a little bit of time because we need to gather information from you, but we also then will work with you to really get at what's most urgent. And then we will set you up with ongoing appointments with a therapist who will see you for 1 time or 2 times, and as many as 7 or 8 times, depending on what you need. Again, you will not be charged for those 7 times or 6 times or whatever they are. After that point, the goal is to get people over the hump of being really urgently in need of care, and then to get them to some other kind of care. Some people say, yes, I would really like ongoing care and I would like it to be in person. And so we work to connect you to care, and I'll talk to more about that connection process. Some people say, no, I prefer to be at home on my couch like this lady and on my computer and interact with you that way. And so we will connect you to care that is virtual. But some people say, you know what, you got me over the hump. I think I'm doing all right. I don't think I need care. And they go out for a picnic and whatever. So those are the 3 options. The thing about connecting to care is we actually locate a place in your area or that will take your insurance, because at that point you will need to pay for care once you leave the AR Connect program. So we help find someone who will accept you, who will do it in a timely fashion, and who will and who has the right financial arrangements to match your particular situation. We then help you establish an appointment, and if you and we don't consider you having discharged from us until you have made an appointment and kept the appointment. So we interact with you to make sure everything goes well with your new appointment. Okay.
Dr. Hudson, we did have a question come into the chat. If you want me to just interrupt you. Okay. Does Arkansas have a shortage of mental health doctors? I have heard we have a huge shortage and it's hard for people to get help in a reasonable time.
So one of the challenges was indeed that there are a really limited number of providers available, and that and particularly in rural areas. And so one of the reasons we hired many new people for this program, and some of them were people we knew because we had trained them, so we brought them in from our own training programs, from others are from elsewhere. And so this really addresses that problem of lack of ability to get an appointment. And so the providers that are out there are usually booked several months out. And so this is why this program's so special, is you can get in quickly. We can get you in, like I said, it's usually 1 business day. We can get you in quickly, and we can stay with you and then work with you until we can get you an appointment in a longer term situation, if that's what your particular need is. So this really overcomes some of that shortage. Okay, so just a little breakdown of kind of how it all works. I talked about, we get a lot of phone calls. We get, about 15% of the calls don't schedule an intake for any number of reasons. So it can be the wrong number. It can be, oh, I was looking to make a regular appointment at UAMS. It can be any number of reasons. Then, but about 85% we schedule some kind of intake. And we do have some that don't show up. But again, a little over 85% engage with us. And upon assessing them, what we find out in some people is, oh, they actually are looking for help for food insecurity, or they're needing housing help, or they need, and so we have developed a whole website to help people navigate that, and we will help them navigate that. We will say, well, gee, the food banks in your area are these, and here's the contact information. And then about 90, a little less than 90% really engage in treatment and say that yes, they want to continue treatment. But at that point, about 20% fall out of treatment, and we're working on how we re-engage those. I've broken those down for you to see that most of these are individuals with we call it serious mental illness. And what we mean by that is it's causing them a pretty serious problem at that point in time, or they have a substance use problem, or both. Some of them are healthcare workers, just a few. And then some are people that feel their problem is not very severe right now, but they felt like it'd be nice to go ahead and get some treatment going. So that's kind of what our clients look like. They are mostly, you can see about 60% come from Central Arkansas. Another almost 15% come from Northwest. And then the rest come from areas, these other three areas. We are particularly concerned that we are not reaching rural Arkansas well at all. This is a very concerning problem, and I'll talk a little more about that momentarily, but we really are, we know that mental health care is really not easily available in rural Arkansas, and yet we want people to know it's just a phone call away. We're here to help. Okay, so of those clients, oh, and this should be 788 now. I apologize, I didn't update my table completely. So generally speaking, people who call us are about 37, and but they range from people who are 6, so children, up to older persons. We had a client who was 93. So, and our therapists have experience with individuals who are very young and older. So we're excited that we have such a broad range of clinicians available. About 30% are Black or African American, not quite 3% are Hispanic. The majority, not surprisingly, are white or Caucasian. We have other that's about 1.5%, and then a few that we don't have their race. And then, not surprisingly, 2/3 of our callers are women, and that's really not that surprising. And my apologies, I updated the percentages and not the numbers. And I apologize for that error. I'll send you guys corrected slide set if you want them. Okay, so we do several rating scales, and I'm just going to fly through this because I just want to quickly give you this information. But we do a GAD-7. And mild anxiety it's a rating of 0 to 21. Mild is the 5 to 9 range. 10 to 14 is moderate. 15 to 21 is severe. I'm going to just jump through these things. PHQ-9 can rate from 0. Its range is 0 to 27. Moderate is 10. 15, 20 are moderate and severe, respectively. The PTSD is a trauma screener. PTSD-5, it goes from 0 to 5. Probable PTSD is when you answer yes to 3 out of 5 questions. So what I have here is for the clients, for those 788 or so clients that we have data on. These, the blue bar is what we call their baseline. So what was their score on a particular measure when they first were seen by an AR Connect clinician, and what was the score at the time they moved to see another clinician or were discharged from AR Connect. And so you can, and these are the mean scores of all of the people, not just one person. So the mean score of anxiety on the GAD-7 when people came to AR Connect was 14.7. And so fairly, somewhat severe, and 10.7 when they moved to another clinician. So they weren't entirely resolved, but they were better. Interestingly though, on the depression, we saw almost no difference, although this increase was statistically significant. So we're still trying to figure out what's happening there and why we're seeing that. And then the trauma actually declined somewhat, and again, that was statistically significant. So we've had a good resolution of anxiety. Depression increased slightly, we're not sure why, and trauma declined. So we're still working this part out. We did a survey. One of the things we do is assess food insecurity, because that's a common reason people are calling us. But what we found is the majority of our clients, and we're using the USD Adult Food Security Survey, the majority of our clients are saying they're highly food secure, so they're comfortable with their food. But we do have the orange pie is marginally food secure, low food security, and then about 15% of our clients have very low food security, hence the need to have resources to help with that. Okay, so I want to tell you about something, a data collection tool called the GEPRA, and I'm telling you this because clients don't like it, and it is a real challenge, but I want to be sure I'm giving full disclosure. GEPRA is a data collection tool that SAMHSA requires all its grantees to collect these data, and it's mandated by Congress, so SAMHSA doesn't have the power to waive it. The thing is 24 pages long. It asks a bunch of detailed questions, and each person is asked to take it twice. And just so you can get a sense of all the different kinds of questions it asks, it asks about what behavioral health diagnoses have you had in the past? Detailed questions about opioid use disorder and alcohol use disorder. Military history, current drug and alcohol use, living conditions. It even asks about criminal justice status. And so I'm telling you all of this because this is a real turnoff to clients. And here is the important thing. If the client will allow the interviewer to ask a couple of the questions and then review them, and then they want to refuse, they can, or they can refuse just any questions that come up. And so we're trying to educate clients about that, but after all, people have the right to disclose what they wish to disclose. And so that's no different with this survey. And so I just want to make sure that that you're aware that yes, we're going to ask a bunch of questions, but we will do that after therapy is started. Getting treatment is not, we don't require you to answer this before we will provide treatment. We feel like that is unethical, and that is not what we do. But we do ask each person to complete this, and I wanted everyone to know that people can decline if they choose to do so. Okay, so I wanted to tell you a few success stories. So we had one gentleman who was 54 years old. He said he had been a alcoholic for 30 years and had had trauma as a child. He lost his job during COVID and had to stay home, and he was homeschooling his 7-year-old son. During this time, he started drinking even more. Unresolved trauma feelings surfaced. He was just struggling to care for himself, much less his child. He was in treatment with us for 6 weeks. We connected him to resources and to medication management for his anxiety. And actually, he's now he's actually several months of sobriety. We check in with him periodically because he was so generous to help us. And he credits the AR Connect program in many ways. He said, first off, it was easy. It was very easy to get help. Secondly, he said he didn't like driving to a clinic, sitting in my car and second guessing my decision to see someone, going into the clinic and waiting and wondering if people were judging me while I was waiting, and then trying to have money to pay for everything. And this is my favorite quote: because of AR Connect, I was able to get the help I needed at just the right time, in just the right way. So he loved getting it virtually. He felt that was just met his needs well. And again, we check in with him, and he is still sober. We had a teenager who had extreme anxiety, including social anxiety disorder. And she said, AR Connect taught me how to, I love this, shock collar myself into catching those negative thinkings and catastrophizing and challenging those thoughts so that I can change them. There was another gentleman, 24-year-old male with schizoaffective disorder and a history of substance abuse, which is schizoaffective is one of the more serious mental health problems that can be really challenging for people to manage in their lives. And this person reports that I felt better and more helpful now than ever before. And then this last one is a 50-year-old woman that I just particularly like. She was a victim of domestic violence. Her AR Connect therapist helped her get resources to get out of that situation and therapy to manage her trauma from that violence. And she says, because of what I learned in AR Connect, I'm now a group leader and mentor for my domestic violence program. So this woman is passing along what she learned, which just, I am just so excited that not only is there a program that helps her, but she's passing it to others. So that brings me to the fact that Arkansas needs you and AR Connect needs your help. So first off, reach out to your friends, family, and neighbors. People are hurting right now. And having, even if it's a virtual reach out, a phone call, a quick text message, a couple of times people have sent me little funny cartoons via text that just made my day and just gave me that little extra boost to make me feel better. And so I encourage you to reach out to others and see how they're doing. And in the past, people have said to me, well, if I reach out to somebody and they're having a problem, I don't know if I can help them. Well, now you have something you can urge them to do. You can help them call AR Connect. You don't have to just give them the number. You can say, how about I come over there and call with you? Or how about I dial my phone and let you talk? AR Connect has the capacity to care for more Arkansans. We actually are not entirely full, and we've started expanding our hours on the weekends to make it possible to have weekend appointments. So we have capacity, but we're really struggling to reach everyone. And I just showed you the map that in Arkansas, we're really not reaching rural areas. And that is one of our target audiences. We really want to reach rural areas because we know that there are struggles to be seen by a mental health professional. Arkansas Connect, one of our goals is to help healthcare work personnel and others just deal with stress. So you don't have to say, oh, I think I'm depressed or I think I have anxiety. How many times have you said, oh, this COVID-19 is just stressing me. My kids are unhappy, my spouse is unhappy. Recently, somebody said, you know what, even the grocery store isn't stocked properly. It's missing, you know, basics. And I'm just tired of this stress. We can help with stress. We can help healthcare personnel with stress. We can help the regular, ordinary Arkansan with stress. So I would urge you to really do two things, and I'd be interested, if we have time, if you have suggestions for me how to better reach rural areas and to better reach personnel, healthcare personnel, I would really love to hear it. I think you only have one more and then we can stop for questions or comments. Yes, so here is the call center number. There's a local number if you happen to be in Arkansas and there are in the local area, and there's an 800 number. We are, again, the care is provided virtually. The clinicians are all located at the UAMS Psychiatric Research Institute. There's also a place on the web that you can get additional information, and we have an email address where you can email us. With that, I'll stop and see if anyone has questions or comments or suggestions for me.
Well, I had a question, and I don't want to put her on the spot, but I think I may. Chelsea Weaver has asked about the type of outreach being made in rural communities, but she may also have some suggestions for you. She didn't say that, but I know that's kind of what you were asking for, ways to do outreach in rural communities. So Chelsea, do you want to chime in here if you have any suggestions on what could be done? And have we?
Hi, I'm here. Sorry about that. I don't know that I necessarily had any suggestions. I was just really kind of wanting to see what they were doing.
Okay.
Sure. So one of the things we've done is a number of TV spots that, and I'll have to admit that with TV spots, I'm not always clear how far their reach is, but we've done 10 or 12 of those now. I've also, we've sent flyers to clinics, primary care clinics across the state of Arkansas, asking them to put them in their waiting rooms for clients or to give them to clients. And I mean, I've sent out probably a couple of thousand of those. We have, what else have we done? We've done several presentations to groups that request them. So one was a presentation to the Arkansas Rural Health Partnership, to clinics and to hospital leaders in their associated with that group. We are starting an additional outreach with the Arkansas ACI is helping with this. Arkansas Center for Health Improvement, Dr. Joe Thompson is helping with this. It's called the Municipal League. So we're developing new materials to reach out to the Municipal League to encourage them that their employees can use this service. And that hasn't quite started. And then we also just received funding from Blue and You from the Blue Cross Foundation to do a statewide outreach to schools, and that will include the school personnel, teachers, principals, housekeepers, everybody, the students and the parents. So that's going to be in, and we're using a professional PR firm to help us with that. So we're, that's what we've done so far. If you have other suggestions, I would love to have them.
We did have a question about, is there a toolkit we can share onto our social media? And she goes on to say, I'm with the Planning and Development District and would love to share the information. And I know that you have a lot of individuals that are on here today that are in positions where they could share it and it would reach rural communities. So do you have a social media page or any kind of a toolkit?
I don't have it where I can flash it up here, but if I sent it, could I send it to one of you and it could be distributed?
Yes, we can definitely get that out.
Okay, then yes, we can make that happen because I don't have it where I can flash this up.
Okay, yeah, we will get that out to everyone. And then had another suggestion about, it was also about social media and targeting social media in rural areas. I think, that's going to be a good way to go. Municipal League is also great. The County Judges Association for Arkansas might also be a good one with their employees.
Yeah, our effort with, I told you we were teaming up with Arkansas Center for Health Improvement because they touch a lot of different groups across the state, and they are going to help us reach the judges as well. So it sounds like we're on the right track with the judges.
Yes, and the planning and development districts that are partners with us on this, their boards for their districts include county judges and mayors, so they could help reinforce what you're putting through the Municipal League and the County Judges Association.
Right.
So very good. Okay, and we have someone saying, I'm happy to ask my ARcare Rural PCP Clinic contacts to share AR Connect resources on their social media too.
Okay, so I will get the social media information to you, and then if you wouldn't mind distributing to everyone, because we would definitely welcome that any help. And I'm going to put my email up here again. I had it on the original slide, but at any time, if you want more information, I'm happy to supply more. But I'll get this social media packet out to you.
That's great. This is so timely and needed right now for sure. We had another suggestion come through about sharing information with church leaders and religious associations would also be helpful. That may be something you're doing, but if not, there's another suggestion.
So we have not, and I've really struggled how to reach faith-based groups. And I would like to reach faith-based groups, but I don't know how. And that is, I know how to go from church to church, but that's inefficient when there's just a few of us doing outreach. So do you have suggestions about the best way to get to churches, or do I literally need to go from church to church?
If anyone has any suggestions, feel free to chime in. I think your county judges should be really helpful with that, because counties sometimes have pastoral committees where the ministers all get together. I don't know that every county has it, but I know some do. And so that may be something to mention to the County Judges Association when working with them.
Okay.
I also think like the Methodist Church has a bishop located in Little Rock, and so just going maybe even to the communications directors for the different state organizations, like the bishop for the Methodist Church, the different Baptist organizations, I'm sure have a statewide group. If we have any Baptists on here, you can chime in. But that's my suggestion. A really good place that I think would be the county judges, because they would be tapped into all of them. Okay, and so the PDD, someone with the Planning and Development District saying in their social media posts, they can ask to share at their churches too.
Oh, okay. Yeah, that'd be great.
That would be good. Here's another question. Are there funds to sponsor a table booth at local fairs this fall?
Maybe. Yeah, we probably could if I knew where to go. If you can email information to me,
Okay.
I would love to talk to the public about it. I have a bunch of different projects I'm responsible for. This is by far my favorite because no other state used their money in this way. And so no other state can say, you can get mental health care by calling a number. We won't charge you for it. And we'll try to facilitate getting care on the long term if that's what you need. No other state does that. And Arkansas doesn't get that many bragging points.
Yeah. No,
It's amazing.
it is a fantastic program that's so needed right now. And so, yeah, I'm excited about this because now we can all work on this together and help get the word out. And I think there is a list of all the different county fairs. And so we'll see if we can locate that and get that to you.
Okay.
And then one more came through that you need to be interviewed on Talk Business and Politics in Arkansas Week.
Well, let's see. I don't remember who was interviewed on Talk Business. It might have been Rick Smith, but he's been, Rick Smith he and I wrote this grant with the state, and then he retired. But before he retired, he was interviewed on Talk Business. But we would welcome going back to Talk Business. I'll look into that. But yeah, we've been on several TV channels, on Talk Business, on NPR, for just a general public health radio interview, but also on Talk Business on NPR. So, but we're happy to do it again.
Does anyone have any questions for Dr. Hudson about the program? Oh, they just sent a link to all the fair information. Someone did. That's great. We will email that to you.
Thank you.
This was great information. We're so thankful you were with us today, and we will certainly help get this distributed out to all of our groups in rural areas. And so if there are no other questions, then we will let everyone head to lunch, and we will see you back at 1 o'clock. Thank you so much, Dr. Hudson.
Thank you all for having me. I appreciate it.
Well, welcome back. I hope everyone had a good lunch, and I can see that we have a lot to are running behind from lunch, but I'm going to go ahead and get us started on time because we are extremely fortunate to have our next presenters, Tom Morris and Ellen Morgan, with us today to talk about healthcare workforce resilience. Tom Morris serves as the Associate Administrator for Rural Health Policy in the Health Resources and Services Administration, what we call HRSA, of the U.S. Department of Health and Human Services. In that role, he is charged with advising the Secretary on rural health issues and rural policy. The office, which has an annual budget of $317 million, administers a range of research and capacity building grant programs that serve rural communities. In 2015, Tom received the Presidential Rank Award for Meritorious Service. Alan Morgan was recognized among the top 100 most influential people in healthcare by Modern Healthcare magazine. He serves as Chief Executive Officer for the National Rural Health Association. He has more than 30 years' experience in health policy at the state and federal level and is one of the nation's leading experts on rural health policy. Gentlemen, welcome, and thank you so much for spending time with us today, and I will turn it over to you and let you start on your presentation.
Great, thank you very much. Let me pull up my PowerPoint here. I'll share screen. There we go, from beginning. Wonderful, love it when technology works. So I think how we'll structure this is I will go first with the National Rural Health Association. What my intention is to provide a overview of what we're seeing in rural communities across the US right now. And then I'm going to talk about the impact of COVID, obviously. And then I want to share some solutions that Congress is working on to try to address some of the issues that I highlight during my brief presentation. Then I'm going to turn it over to Tom, and Tom will be able to provide the administration's response to rural health challenges and opportunities as we go ahead. So hopefully by this structure, it will be a coherent and easy to understand presentation for everyone attending, regardless of whether you've been engaged in rural health for decades or whether this is a new area for you. So let me start just with a little foundation here. Number one, I represent the National Rural Health Association. This is a nonprofit membership organization. If you care about rural health and rural populations, there's a home for you in the National Rural Health Association. We represent more than 90% of the nation's rural hospitals, rural health clinics, and rural community health centers, but we're much more broad than that. We actually also, our membership includes researchers. We publish the Journal of Rural Health, educators, and including also some of our most active members are state employees who oversee rural programs within their states. So, and separate from the federal government. So you'll have an external view and an internal view in this presentation between Tom and myself. So let's first set the table for talking about rural health. I love this slide because it highlights the challenge that we all have. What a great picture, right? You see the father and the daughter looking out in the sunrise. I think this is what we all would like rural America to be, and in many regards it is. In many cases, it's a Hallmark episode movie come to life. But this father and daughter are looking off in the sunrise and they see workforce shortages, vulnerable populations, and chronic poverty. And that's the challenge. How do we tell an authentic story about our communities? The media often portrays rural America either as the Shangri-La Hallmark version or a dystopian hellhole that people are dying and trying to get away from. And the truth actually lies somewhere in between. What I really appreciate from rural is because of these challenges that rural communities face, they are innovation incubators. All of the innovation that we're seeing in our nation's healthcare system really has an origin in rural communities where they're faced with these pressures. So you can really see where United States healthcare is going to be 20 years from now by looking and seeing what's happening in rural communities today. So for the purpose of this discussion, as you might expect, unfortunately, I'm going to focus heavily on the challenges because it's in the challenges that we see the opportunities for improving the status of rural health. And even pre-COVID, rural America faced tremendous challenges of vulnerable populations, systemic workforce shortages, limited resources for the providers that are in those communities, and overall low reimbursement rates. But again, these pressures are exactly what has given rise to concepts as community health workers, patient navigators, dental health aides, and even telehealth and telemedicine. Now, sure, NASA has taken a large role in the development of telemedicine, but what's more rural than within space? The point being is these pressures drive innovation. Now, you see these pressures most notably in healthcare disparities. It's so easy to remember the phrase, rural is older, sicker, poorer. If you watch the CBS morning news program from this past weekend where they talked about EMS services, the segment opened with that statement, rural is older, sicker, poor. An elderly population and a population in many cases with multiple chronic health issues. This map, unfortunately, the design of this map, the shape of this map, lines up perfectly, unfortunately, with rural populations. If you overlay our membership at the National Rural Health Association on top of this, you just see the same pattern emerging. And this same pattern also emerges in diabetes, hypertension, obesity, heart disease, stroke, COPD, and also, as you'll see later, COVID as well too. Where you see these rural counties, they show up as unfortunately, populations with serious and significant healthcare needs. And in these populations with these high health needs, we also see significant shortages of providers. In rural America, 77% of the rural counties nationwide are primary care HPSAs. So this really sets a stage that rural is not a small version of urban. Rural is a unique healthcare delivery environment where those most in need of services oftentimes has the fewest options available to seek that care. Now, that was true before COVID. And what we've seen over the last year and a half is these disparities and inequities just simply have been highlighted as we face the pandemic together. It's important to note that from a rural healthcare standpoint, rural hospitals are designed for primary care, general surgery. They were never designed to deal with a global pandemic. That's just not how healthcare is designed. So regardless of whether you're a conservative Republican or a progressive Democrat, chances are you probably see me on TV at some point. I want to put this up here just to highlight that, yes, there are many political aspects to COVID, but when we're talking about it and what we're seeing is there is a uniquely rural aspect to this that supersedes any politics. And whether I'm speaking on MSNBC or Fox News, the issue of rural health and rural health care delivery is bipartisan. And I feel strongly that we always stick to that component. It's rural healthcare is something that actually can unite the political parties behind how do we improve access to care and standards of care in rural communities going ahead. So let's talk a little bit about what we've seen just this last year. And what I'm going to do is Zoom always places your faces on the right-hand side, which actually covers up the part of the chart that I really want to show. So I just pulled my pictures over here to the left-hand side. I'd suggest you do the same so you can follow the chart I have here if you can't see it all on the screen. So this is really important when you look at the graphs because you can hear all different sorts of information coming from all different sources on COVID. But what I want to do for this next session is put the politics aside and just look at the actual impact of COVID on rural communities. And I'll come back to this slide because you kind of have to match these three slides I'm going to show you together to really see the impact of what we're witnessing. And the point being is during the spring surge, we actually saw a corresponding level of COVID, rural and urban, and which was exceptionally high. But that correspondence traveled throughout this year until about mid-July. And that's where we've seen this divergence among cases per population, rural, urban. And what we're seeing now are significantly higher cases in rural communities than what we're seeing in urban communities. Now, you all know that mortality trails cases. So let's now look at mortality over the same time period. And it's amazing to see back in the spring when the cases were at comparable rates, nonetheless, mortality was significantly higher in rural areas. Mortality was significantly higher in rural areas. But the really disturbing part that I think now is now when you look down, despite the fact that the cases, and I'm going to go back, you saw the cases were the same, the mortality was significantly more. Now you're seeing the deaths, the mortality from the end of July significantly increase in rural communities. So going forward, as we continue now actually to see a divergence going ahead of seeing more cases in rural, what does this portend for rural communities when it comes to COVID going ahead? These charts are actually from a week and a half ago, which surprisingly in the current pandemic don't hold up well to what we're seeing right now. And in fact, if you followed NBC News this morning, you'll see that COVID is now killing Americans, rural Americans, at twice the rate of urban populations. Where do we expect this trend to be this fall? Anyone's guess is as good as anyone's on here, but this does not portend well for what we're going to see for rural communities at the end. This is disproportionately impacting and killing rural Americans at this point. And the only thing that has changed to actually diverge off this chart, what has changed? What is driving this separation at the end in cases? The only variance on this are vaccination rates. Currently, rural vaccination rates are roughly 39% of the rural population, significantly trailing urban populations. So regardless of your feeling on vaccinations, you can see the actual correlation between the vaccination rates, urban, rural, and now what we're seeing is the split in both cases and mortality as we move forward on this. So not surprisingly, this is one of the key reasons why the Biden administration has now mandated vaccines going ahead. Now, it is really to how do we address this rural-urban divide in mortality? Now, does every rural clinical worker need to be vaccinated? Yes, because these workforce shortages are identified, it's really important to see all rural clinicians and hospital workers vaccinated, 1. 2, this is not an either or. We do know because of the significant workforce shortages, we need to plan for health service delivery disruptions. They will happen. This is not a hypothetical, it's going to happen. For the states that are currently mandating this, of California and New York, we've already seen the governors in those states announce that they will bring in National Guard health staff as needed to help address any shortages from health professional staff leaving because of the mandates. What we're looking for now is hopefully a similar plan from the federal government to be able to utilize public health service professionals, FEMA teams when needed, allowing provider relief funds to be utilized to hire traveling nurses, utilization of many of the programs within Tom Morris's bucket within the Health Services and Resources Administration. The federal government has a lot of tools to be able to partner with local rural providers to make sure that we don't see service disruptions in this. And when I say that, what are we really talking about? Well, at the beginning of this year, our organization actually surveyed our membership to try to get a sense of where we stood. And back in February and March, it was disconcerting to us to see that the hospital staffs were mirroring, in many cases, the communities they served. And by that, I mean, it wasn't unusual to see up to 40% of the hospital staff with no intention of getting vaccinated. We are currently surveying our members right now to see if that number has budged over the last 6 months. But the problem remains that there are a significant amount of rural hospital workers that simply do not want to be vaccinated. And when we have vaccine mandates in, we have to have a plan in place to make sure, again, we don't have service disruptions. I do want to say this because I think this is important and a great takeaway. We asked those same workers the reasons for not wanting to be vaccinated. And again, this is a rural slice. This isn't an urban perspective. This is a rural perspective. And the vast majority of them indicated that this was not an issue of lack of trust in vaccines or safety concerns or existing health concerns. The vast majority of rural health providers and those within the hospital walls cite a matter of personal choice as the reason why they're choosing not to become vaccinated. So again, as an association, after this session is over, go on the internet and type in rural health, just rural health. Our website is always one of the first 2, 3 that pop up. And we actually have tools and resources that are targeted specifically towards rural communities on how to talk about vaccines and the relevance and importance in a rural context. And again, we've just found from surveys and from research to date that the federal government telling rural populations they need to get vaccinated doesn't really work that well, but rather having a conversation of what do we need to do within our community to keep our businesses open, our kids safe, and our healthcare workers on the job? What do we have to do as a matter of civic pride? What is our choice here? And those are the tools and resources that we want to provide to help change this conversation away from the federal government's telling you what to do to, hey, what do we have to do within our own community to keep us safe and keep us on the job as we move forward? So ongoing discussion, but at the end of the day, this whole discussion gets back of in a population that has significant healthcare disparities and chronic health issues, a limited resource available. How do we make sure that healthcare service is not disrupted in this process as we go ahead and people remain safe? I'm going to talk a little bit about equity within rural communities, and not just geographic equity, but equally important, in many cases more important, population equity. This is a map of hospital closures over the last decade and what has happened to date. And while we've had 138 closures to date, we see that Arkansas is not great, not tremendously bad, but not somewhere in the mean of where we're at. So let's now take a look at what we see project going forward, and you see that Arkansas has moved up on that level. I think this is important to note, and I want to talk about equity in this concept. When you talk about rural health, there's always a discussion, well, rural hospitals are closing because they don't have volume. It's the lack of volume. If that really was the case, we would see most of rural hospital closures be occurring in Western Kansas, Western, North and South Dakota, and Nebraska, because that's where we're seeing tremendous population declines. But that's not the case. We're seeing these rural hospital closures, as Shep Center from the University of North Carolina highlighted, predominantly occur in populations, in communities, in rural communities with high percentages of African American populations, Latino, Hispanic populations. This is an equity issue. And not surprisingly, we've seen that in the result of primarily in the states that have not expanded Medicaid. You simply see these rural hospitals and rural providers seeing too many patients with the inability to pay for care. And now we're seeing that spread as we're seeing the insurance market change and the prevalence of high deductible, high copays, which now is impacting many more rural hospitals than it had in the past. Simply stated, rural patients are showing up at their physicians or hospitals. They have not met their deductible. They're sent on for specialty care, and they have met their deductible. And so as a result of that, you see the large health systems and urban systems receiving full payment for those services. And unfortunately, rural providers are left holding the bag. Not surprisingly, we're seeing hospital closures as a result of that. So this isn't a mystery. We know what's happening here. And Congress is working to try to address that. And it's exceedingly confusing right now, trying to keep separate the three large packages going through. I just want to try to cleanly articulate these before I turn this over to Tom. Number one, infrastructure package, the $1 trillion bill. This actually has funding for broadband connectivity, which is so very important in our rural communities. It is a much more narrow package, which we're talking about right now. A larger package, the Build Back Better reconciliation package, is one where we see the potential for a lot of new rural provisions to include within this. We are seeking grants to improve healthcare infrastructure, changes to telehealth, and other measures to make sure that we've got the funding in place necessary to help these rural communities. So you've got the infrastructure bill, the reconciliation bill, which is much larger, and don't lose track of appropriations, which also is going through the same time. Now it's fully expected that the appropriations efforts are just going to be a continuing resolution to carry us through to the next year. But I just don't want to shortchange the relevance and the importance of these appropriations discussions. They fund the activities that you're going to hear next from Tom Morris. They fund rural hospital technical assistance programs within the USDA in addition to that. And they fund overall efforts to help expand the use of telehealth across the US. Okay, as I finish up here, just a couple focused issues. I mentioned telehealth twice during this presentation. Telehealth is a great tool to improve access to care. It's not the solution of this, but it has been an amazing resource. And what we've seen is at the beginning of the pandemic, telehealth utilization dramatically increased. Since that time, it's really fallen off. And unfortunately, it's plateaued, but urban use of telehealth has plateaued at a much higher level as rural going ahead. I'm encouraged that changes within the physician fee schedule will now promote and enable behavioral health telehealth application to continue going ahead in federally qualified health centers and rural health clinics. That's great. Perhaps more importantly is the use of only telephone services, not tied to video going ahead. Because in so many of our rural communities you drive through, you just don't have that video capacity. And so that continues to be a problem, and certainly as we struggle with broadband going ahead. Again, telehealth is a great resource, and what we're seeing is while there's widespread adoption of teleradiology and teleconsultation, that's clinician to clinician talking, what we really want to see is what we were promised from the Jetsons, and that would be telehealth from a clinician in a rural health clinic out to the patient's home, really meeting the patients where they're at in a rural context. I can't leave a discussion about challenges and opportunities in rural health without talking about behavioral health. It's certainly a central figure in what we're talking about. A tremendous amount of funding over the last 5 years has been promulgated and put out there dealing with opioid health, dealing with the opioid crisis, I should say. I just want to make sure that we're all clear in a rural context, we're dealing with a substance abuse crisis. And in a lot of communities, we've had successful interventions to tamp down the opioid misuse. But in those communities, we see the rise of other substance abuse issues, most notably the high utilization of meth, which is easier and cheaper to get than the opioids. And so in any context of this, we really have to talk about how do we make sure that we have the access to behavioral health specialists that work in a rural context. And again, this is where telehealth falls in. Just the clinical measures of success in treating opioid disorder and behavioral health issues using a telehealth application in a rural context. You just can't understate that going ahead. Finally, I want to close on the need to modernize the rural health clinic program as we go ahead. There's roughly 500 rural community health centers across the US, but there's more than 4,000 rural health clinics. And the important thing on this is to make sure that we're collecting data on quality and on the patients in these communities going ahead, and to be able to direct federal resources and state resources to help these provider types. Earlier this year, we saw a change in the regulation and unfortunately included a barrier for some provider-based rural health clinics, those rural health clinics attached to rural hospitals. So we're hopeful within the reconciliation package, which I alluded to and talked about earlier, that we'll see some of these concerns addressed. But it's just really important to note of the connected nature of rural health and the importance and relevance of collaborating within rural communities to ensure access to high quality health care. I hope what I've done during my presentation again is provided a brief overview of the challenges and opportunities facing rural communities, a focused look on the impact of COVID, and then a more targeted look at what we're seeing from Congress right now pertaining to rural health. At this point, I'm going to turn the stage over to my co-presenter, Tom Morris, to discuss now about the administration's approach to this. So I'll stop sharing and I'll turn the stage over to you, Tom.
Okay, thanks so much. I'm going to pull my slides up. And all right, are y'all seeing that? How's that?
That's great, Tom.
Yes.
Okay.
Looks good. You might need to swap your display settings for presenter view. So go to the drop down on display settings at the top.
Yep.
There. And then swap the first option.
Great. Thank you. Nobody wants to see my notes. I don't blame them.
There you go.
Thank you very much for the help on that. And thanks for the opportunity to speak to you all today. And, I'd like to do what I can to build on Ellen's points. And then, there's no doubt the challenge we're facing in rural communities. And you all know it far better than I do. I live up in the bubble of the Washington, D.C. area. And so, you're facing it on a daily basis. And so what I hope to do today is talk a little bit about some of the things we're trying to do, to help out with the response and some of the resources that may be available and hopefully, make them more aware of them, and then to the extent that they can help folks in the community, all the better. So anyway, just a little bit first about the Federal Office of Rural Health Policy. We are charged with advising the HHS Secretary on rural issues, and so we sort of have a goal of looking across the Department of Health and Human Services and seeing about not only what we can do with our own program resources, but the larger realm of HHS programs and making sure that they're paying attention to rural issues also. And so we have this sort of dual role in the sense that we do that department-wide effort, but then we also administer a range of grant programs that I think at their core are mostly about capacity building, either at the state or local level. And so hopefully you work closely with your state office of rural health there in Arkansas. We have a state office of rural health in each of the 50 states, and they're really critically important partners for us. Then the other thing that would just like to note that we do is that we also invest in rural communities around pilots and demonstrations, and I'll talk a little bit about that. We support a range of rural health services and research because it's hard to argue policy if you don't have data behind it. And then, we make sure that we can help people navigate the bureaucracy. And so if you have any issues that come up where you're curious about something, please reach out to us and let us know if there's anything we might be able to do to help you in that regard. But just to, as Alan noted, I think he laid out the case really compellingly about the challenges we have. It's been very interesting and sobering to sort of watch how the pandemic has played out. It was sort of delayed coming to rural America, but then really hit with a vengeance. And certainly what's happening now is disconcerting, and it's overwhelming, healthcare systems across the country. But considering the small scale of rural hospitals and the rural healthcare delivery system, it's even more impactful, I think, in rural communities. And, the effect this is having on the workforce, gosh, I can't even imagine. And then ultimately, this has a broader effect on people, in the community at large, and their ability to get care. So, I think we've tried to do whatever we can. We've been happy that the Congress has provided us some resources to try to help with the pandemic response. And so that's included money that we've been able to send to rural health clinics and to small rural hospitals. And it also includes money we're doing to do vaccine confidence. I'll talk a little bit more about all of that in a minute. So right now we have 3 programs I'd like to mention. This testing and mitigation program is one of them. And what we've done there is provide money to rural health clinics and the small rural hospitals. And, they can do testing, but they can also do this word mitigation, which is really broadly speaking, anything they can do in response to helping communities adapt to the pandemic. So it can be restructuring services, it could be purchasing supplies. We are really looking at this as broadly as possible and giving the hospitals and clinics as much flexibility as we possibly can in doing that. And so I know that your focus today is provider resilience and what we can do for the workforce. Our hope is that this money provides a little bit of flexibility for these cash-strapped clinical locations, to adapt to some of this. And that if that then helps, alleviate some of the concerns for the staff, then all the better. The other thing that we're doing is providing additional access to vaccines through rural health clinics. And you may know that like the HRSA runs the Community Health Center program, and we've been distributing vaccines through the health centers for most of the past year. In the spring, we stood up a similar program for rural health clinics, and Arkansas has quite a few rural health clinics, as you can see from the middle map and those dots. And so what this program allows you to do is above and beyond the state allocation of vaccines, you can order directly from our office, and we work with the CDC, and you get your choice of any of the 3 vaccines. And so it's not meant to displace any of the state efforts. It's meant to be an add-on. What we were trying to do was just make sure that we really targeted areas of great need. In many cases, rural health clinics are in communities that are not served by a federally qualified health center or a hospital. And so to the extent that we can get more vaccine into their hands and their trusted providers in their community, and they can then get that vaccine out, then all the better. And so we were happy about being able to do that. We've provided a fair amount of funding to rural health clinics to promote vaccine confidence as well. So we're really, working on 3 levels here. We want to provide funding and support for prevention and just dealing with the larger issues of the pandemic, and that's through the testing and mitigation. We want to do what we can to give our rural health clinics the money to really get out in the community and help educate people and help them understand the vaccine and answer any questions they have, and hopefully convince them to take the vaccine. And then finally, if they need additional vaccine, and particularly as we enter this phase of boosters, that may be the case. Then they're more than able to order through our rural health clinics. We've got a handful of rural health clinics in Arkansas that are currently ordering vaccine. And what we hear from the clinics that are taking part is that they're appreciative of it. It's a nice bonus on top of what they're getting from the state. And in some cases, it can be easier to order from us than the state. I don't know if that's the case in Arkansas, but it's been the case in some of the other states. And so if you have any questions about this, please follow up. Be happy to connect you to the resources. We have a technical assistance support system in place to really walk clinics through the whole process to do this. And hopefully these resources will be of some degree of help in Arkansas's rural communities. The other resource that's out there is, we recently announced the allocation of additional funds to the Provider Relief Fund. So that's the phase 4 allocation of remaining dollars, as well as the new $8.5 billion rural fund. And so, I think people are still sort of sorting through that. And so what we're trying to encourage folks to do is, hospitals, clinics, you should sign up for both. Don't wait to be contacted. Go ahead and get onto the website and register as soon as you can. The rural fund it's a rural allocation, but it's drawn very broadly. So there are urban entities that can qualify for this. So one of the ways we kept it being particularly focused on rural is that the formula does involve those entities and how many patients they serve who actually reside in a rural community. And we think that certainly will help providers in rural communities get the funds that they need, to offset both the increased, the loss of revenue they're seeing, but also the increased costs they're seeing during the course of the pandemic. And then, since we are talking about workforce today, the administration just a couple of weeks ago has decided to allocate another $52 million to our office. To let us create a new workforce program, and it's under the public health training aspect of the American Rescue Plan. And what we want to do in this program is really fund networks to fund in 4 specific areas. One of them is community health. So community health workers, doulas that can help the maternal care. When we want to cross-train these community-based folks to do not just that sort of lay health worker, navigation and community encouragement work in terms of healthcare, but we think there may be some benefit in cross-training them to do things like enrollment in Medicaid or enrollment in the marketplace plans or enrollment of children in the Children's Health Insurance Program, because that then benefits the hospital because it reduces uncompensated care and bad debt and makes the hospital more financially sound. And so the community health track allows one to do that. We're also looking at allowing the funding to be used to do sort of case coordination. There's so much talk now about social determinants of health and all the things that affect somebody beyond the clinical experience, things like transportation and access to healthy food, employment, job training, you name it. There are a lot of things that affect healthcare outcomes that happen outside the 4 walls of the clinic. And so that's a lot of navigation for some patients. And so it's way too much to put on the clinical team. So what we want to do with this track is also allow people to do that sort of navigation of the human and social service world that hopefully will then link to better health outcomes as well. The funding can also be used to create community paramedicine programs. You may have heard of this model, but basically it takes paramedics in their downtime and allows them to do community health work, health screenings, home visitation, all those things that sort of contribute to community and public health. And there's established curriculums out there that people can be leveraged. And so our hope is that, we've seen this model work in a number of states, particularly Minnesota, Colorado, and we think it could work in other areas too. We have a 3rd track around health IT. Alan mentioned the expansion of telehealth. We know a lot of people are using mobile health applications and home monitoring equipment. People are trying to leverage their electronic health record and the data in there to better target public health interventions. But who's going to maintain those systems in a small hospital or a small clinic or a small substance abuse clinic? It's not like you have, myriad staff that can also, be allocated to doing the health IT portion of it. So our thought with this track was that you can either train existing staff or bring in new staff to help maintain all those systems, but also to train people in the use of them. In other words, training the clinical staff how best to use the telehealth equipment. So that's the third track. And then the fourth track really does lean into COVID. We know that there are a subset of patients that have COVID that then are suffering long-term consequences in terms of their health. A lot of times this begins in the respiratory area, but then can bleed into other chronic disease areas. And so we know there's a shortage of respiratory therapists in rural communities. So with this fourth track, we're encouraging folks to train up more respiratory therapists, but then to also think about chronic disease management. And this will help not only with the pandemic, but our hope is that it will help in the longer run too, because as Alan noted, we have higher rates of chronic disease in rural communities, and those patients have fairly high needs. And so how can we better help them to help themselves in a way that helps them sort of from a case management perspective? So we're going to put the notice of funding opportunity for this program out in November. We want to fund networks. We don't just want to fund community colleges or technical schools or training programs. We want to fund networks to have those educational entities, but also have primary care clinics, substance abuse clinics, dental offices, rural hospitals, area health education centers, workforce investment boards, because we feel like we have to make sure there's a connection between those doing the training and then those who might employ the folks that are the product of that training. And that's really the essence of this program as we've envisioned it. So the reason I'm mentioning it today is because with the guidance out in November, now is the time for folks to start thinking about what their networks might look like, what the governance of those networks might be, so that when the application is available publicly, folks can hit the ground running and really put together solid applications. So if you have any more questions on this or want to hear more information about what we're trying to do here, please follow up with me. Now, you mentioned provider resilience at the beginning of this, and I do want to speak to that. We don't have any rural specific money in this regard, but in HRSA, our Bureau of Health Workforce, just closed the application window on $103 million in provider resiliency support. I think there'll be more funding that goes out beyond this, focusing on mental health of healthcare providers. It'll be both in the hospital sector, but also mental health services. And so I expect more funding to come out of this. This was sort of just the first round of it. Talking to the folks who put this program together, the point they made was that the immediate focus of the funding is on addressing this burnout factor, obviously, but long term, I think that there needs to be more organizational buy-in about how do we support our clinicians, not just during COVID, but really overall, because they are in such a high pressure cooker in terms of the work they do, and especially in rural communities, you never get a break. You're always out in the community, people are asking you about clinical things. And so, you can only imagine the burden that is over time. And so the hope is that this funding will help in that regard. Alan mentioned opioids, because I do want to just close by talking about some of the remaining challenges, because, I do think they affect the workforce. And certainly the opioid crisis has been front and center. And Alan noted that, we've seen an increase in the overdose rate in the past year, and no surprise. We were on a range of opioid programs, and right before the pandemic started, we were just starting to see the benefit of that and getting more people into treatment. And we're really excited about the trajectory of those grants. And while many of our grantees switched to doing services virtually, you can't do all that you need to do in treating substance use disorder virtually. And so the fact is, people fell out of treatment, and when they fell out of treatment, overdose rates increased. And even this graph here doesn't sort of do it justice, because this is aggregate numbers. So it looks like the urban overdose death rate is much higher than in rural. And what we haven't been able to do with the data yet is adjust and make it proportional. And so, our preliminary look at it is that the overdose death rate increased in rural as much as it did in urban. And, so this just creates challenges as we move forward, because we're dealing with two epidemics, right? We're dealing with the COVID pandemic, but then we're dealing with this epidemic in opioids. And Alan is spot on in noting that it's not just an opioid issue. We've long had problems with alcohol abuse in rural communities. Methamphetamine never went away, and yet it is becoming a drug that people turn to because of its easier accessibility. When they're suffering from opioid addiction as well. And so there's some real challenges out there in that regard. Alan mentioned, the other backdrop we face, which is in each of the 5 leading causes of death across the board, we see higher rates of avoidable or excess death in rural communities. And none of this should be a surprise when you have higher rates of poverty, when you have fewer providers, less of a clinical infrastructure, higher rates of chronic disease, all of that. The inevitable outcome of all of that is that rural people die at an earlier age and at a higher rate than they do in urban communities. And they die deaths that if they were living somewhere else would largely be avoidable. The rural hospital infrastructure is certainly not stable. I think Alan's metrics really pointed to this, so I won't repeat what he said, other than to say, if you look at that bottom part of the slide, when we look at the closures, in about half of the cases, people are able to maintain some level of access in terms of like an extended hours clinic or something like that. But in the other half of them, they're just healthcare deserts, and that's the real issue here, is access, and that's the concern moving forward. So even while we're dealing with these issues, and then you put a pandemic on top of it, we've got both these short-term and long-term challenges. So I just want to close by noting that there are some resources available. I think we put forth about $80 million a year in community health grants. This is a unique funding opportunity within the federal government, in the sense that with these grant programs, we're basically providing startup capital for good ideas. The grants are 4 years in duration, although we do have one that's a planning grant that's 1 year in duration. And the idea being is that if you've got a good idea, we'll fund it. And the only thing we ask is that you find some way to make it sustainable in the long run. And we've had some good success with about 90% of these grants continuing their services after federal funding. And certainly you've got some great models with Melly and others in Arkansas who've really made this happen. And so, again, as you think about how you're going to support your clinicians and some of the unique challenges, both pandemic and non-pandemic, that you face in Arkansas, the outreach grants, the various programs that fall under that would be an opportunity to consider. And then I mentioned the opioids issue, and this is hitting so many states and certainly rural communities in those states. And we've got a fair amount of funding to do this. And it's significant because so much of the funding for opioids comes down via state block grants. And that's a wonderfully efficient way to get money to the states and let them allocate. But we know sometimes there's just not enough money that gets all the way to the smaller rural communities. And that was what our program was designed to do, was to make sure that within the broad range of HHS funding around opioids, that we didn't leave out small rural communities, and we helped them build capacity and form networks, with the idea being that they could, increase their prevention efforts, get more people into treatment, build more of a treatment infrastructure, and do it in a way that helped us get on the other side of this epidemic. We also continue our work around supporting rural hospitals. And so we have money that can help around, maintenance, around quality improvement and performance improvement. But then if you have hospitals that are really struggling, we have a program for hospitals in the Mississippi Delta region, and Arkansas is part of that, obviously. And they can get really targeted technical assistance. We also have a vulnerable rural hospital assistance program. And so each year we're working with between 30 and 60 hospitals, trying to help them with their unique challenges they're facing. And then the other part of this to think about is just where we go from here. The rural hospitals face some challenges in moving toward a system based on value rather than volume. And so we have a technical assistance resource that works with facilities on that challenge. And then I'm encouraged that USDA recently put out their rural emergency health grants, $500 million in funding. And then CMS is testing out some new models with the chart demonstration or payment model. And then also they'll be doing rulemaking on a new hospital type in the coming year called the Rural Emergency Hospital, that we think offers a solution for those communities that perhaps are not big enough to support a full service hospital, but need more than a clinic. And so all those are potential opportunities to think about moving forward. And then finally, just to close out on the telehealth issue, it's clear that this has been a lifeline during the pandemic. At HHS, we certainly realized that telehealth is no longer just a rural issue. And that's why we recently moved the Office for the Advancement of Telehealth out of my office, and it's now a standalone office within HRSA. And, so they operate a range of grant programs that can help people either get telehealth programs started or enhance the telehealth programs they already have. They're also really strong advocates for working with our federal partners around broadband access, whether it's the USDA, FCC, or the Commerce Department. And they're also the head of this office, Heather Damaris, is part of a small team at HHS that's really looking at all those public health emergencies and working with the Secretary's office to figure out which of those need to be continued. And then ultimately, it's going to come down to the Congress and the administration making those decisions and figuring out what authorities are needed so that we don't lose any ground with what we've made up during the pandemic, when we've really been able to leverage a discussion on telehealth from one about the potential of telehealth to one now where we're talking about the reality of telehealth and the fact that it's become really an essential part of the healthcare delivery system. And although a lot of the increase has been in urban areas, I think that's a bit of a misnomer because a lot of the utilization prior to the pandemic was in rural communities. So there's already a base of services there. So yes, urban areas have caught up and perhaps passed rural areas in terms of utilization, but telehealth has been an important lifeline in rural communities for more than 30 years. Our challenge now is how to make sure that they continue to leverage this technology and to do so in a way that drives better healthcare outcomes. And so with that, the only thing I would say is we have a weekly announcements that I encourage you to sign up for because we try to put all of our funding out there and as well as other resources that we think will be beneficial to rural communities. And so with that, I'll stop and just thank you for the opportunity to spend some time with you today.
Oh, thank you so much. Thank both of you, Alan and Tom. Do you have time for a few questions? Because I've had some come through already. If you're okay. Okay. The first one is, does the Office of Rural Health Policy have any programs that will provide funds or incentivize healthcare workers to stay in rural areas?
Yeah, HRSA does. And so the National Service Corps, it provides loan repayment and scholarships. There's also a Nurse Corps program that supports loan repayment for nurses and also faculty development for nurses. And then we also administer the state loan repayment program. The National Service Corps is a critical resource for rural communities. I think basically on a year-to-year basis, even though rural population represents 15 to 18% of the population, 30 to 40% of the National Service Corps placements are in rural communities. So that would be the primary one to look at. And the other resource I'd point you to is we support the Rural Recruitment and Retention Network, which is a 50-state network of state-based entities that try to link clinicians that want to practice in rural communities to rural communities that are in need of those clinicians. And they've just recently done a really nice revamp of their website. And I think Arkansas has a point of contact for that. But even if you're not able to reach that person, you can reach out directly to the Rural Recruitment and Retention Network staff. And there's a bunch of resources on there that hospitals and clinics, I think, would find valuable in terms of addressing retention issues.
Okay, perfect. The second one goes right in line with that, but are you familiar with any creative things that are being done in hospitals around the country to keep their healthcare workers from going to other hospitals that are offering bonuses due to COVID or things like that?
Yeah, I mean, Alan can probably speak to this too. It's such a challenge out there, and it always has been, right? But it's just been exacerbated by the pandemic, and there's a certain point at which a rural hospital or a clinic can't offer any more salary, and so, yeah, I think I think what Mike Shimmons and his staff are really good at 3RNet is sort of capturing those stories about what works and why, and thinking about it, and then also within the State Office of Rural Health Community. That's a tight-knit group, and they share a lot of their stories around, and so there may be some things to leverage from there through your State Office of Rural Health. But let me see what Alan thinks.
Yeah, well, they do run the gambit, and from the easiest solution, which is proven over time, is recruiting local kids into rural residency programs or rural nursing programs, and then placing them in that community. Number one, that is the easiest way to deal with it. And then beyond that, the solutions get as creative as, my favorite one is from a Western Kansas hospital, a CEO, a guy by the name of Benjamin Anderson, actually allowed his clinical staff to take sabbaticals, brief sabbaticals, to underserved countries to practice medicine. And that ability for them to be locally in a rural community, but also go to an underserved area overseas was extremely appealing, because it's the same thing that attracts people to rural healthcare, and the ability to do that. So I think there's a lot of those. The Rural Assistance Center online tracks success stories ongoing. We do as well too. It's very easy to go on to their site, Google look up their success stories. There's so many. And again, I would simply state that is a highlight of rural communities, is identifying those best practices, sharing those, and replicating them.
Very good. I have another one in the chat here, and I just want to say to everyone else, if you have a question you want to put in the chat, we may have time for one more. But here in Arkansas, we have 3 medical schools now and a new one that is being built. We only had one 6 years ago. We don't have enough residency programs to keep the students in our state. Many times when they have residency programs in other states, they don't end up returning to Arkansas, their home state. Do you have any ideas on how we can encourage more residency programs in the state?
Yeah, I please don't tell my staff I forgot to put a slide in about our rural residency planning grants. We have around $10 million a year to fund the creation of new residency programs. Even as all of you, many of you may know, we've got the cap on residencies that dates back to 1997 with the Balanced Budget Act. But woven into those regulations is that if you have a rural hospital that has not had a resident before, it can start a new residency program and get support and start a new cap and get Medicare support for that. And we have grant money that can help get you through the accreditation process. We did a grant a couple of years ago with Alan's organization, in which we sort of tried to do this on the cheap. And we still got a number of residency programs created, but the single big takeaway was getting through the accreditation process. And so right now we have 46 communities we're working with to create new residency programs. About a third of those have already gotten through accreditation and are actually enrolling and training residents as we speak. So the only thing we say is we'll get you started, but then hopefully we can transition you onto Medicare, or if your state Medicaid program covers residency training that way, or through general revenue. And it can be for family medicine. We've had psychiatry, we've had internal medicine. This year we're funding our first general surgery residency. And so the other advantage here is that the Congress passed a bill in December that gave extra flexibility for a sub model of that called the rural training track. And this is going to increase the universe of the rural training tracks, because it allows like an existing residency program in family medicine to still become a rural training track by just getting new partners that would be in the rural community. Anyway, it's a long, garrulous answer, but if whoever wants to know more about this, drop me an email and I will connect you to our staff for it, because this may be one way to get more residency programs going.
Perfect, thank you. Okay, I have not seen any other questions, and so I just want to say how much we appreciate both of you for spending time with us today. It was really an honor to have you with us. And we will move right on into our next session on health professionals thinking outside of the hospital. Dr. Brookshield Laurent is chair of the Department of Clinical Medicine at the New York Institute of Technology, College of Osteopathic Medicine at Arkansas State University, and executive director for the Delta Population Health Institute. She's an advocate for health equity and a leader in addressing social determinants of health to transform community health outcomes. As the executive director for the Delta Population Health Institute, Dr. Laurent leverages resources in education, research, policy, and community engagement to bring about policy, system, and environmental change. The Institute aims to create a culture of health in the Delta. Dr. Laurent is also a good friend and partner of the Delta Centers, and we are sure glad to have you with us today, Dr. Laurent. I'll turn it over to you now.
Thank you so much for having me. I am going to just share my screen here. So give me one moment to just have us log on here. Thank you. Which screen can you do you see a full white screen or there's black?
It's full screen, looks great.
Okay, great. Wonderful. All righty. So good afternoon, everyone. I want to thank you again for having me present at the COVID Recovery Resiliency Workshop. I'm Dr. Laurent. I want to say thank you again to Ms. Andrea Allen, her entire team, Ms. Mary Margaret Jackson for inviting me. And we've been really great partnership and doing a lot of cool things together throughout the pandemic. And I'm so grateful for their forward thinking and their thoughtfulness and really just great thought partners. Is when our institution, the Delta Population Health Institute, came into fruition a couple of years ago, they were one of the key people we asked to come to the table, and one because of their inherent understanding of wellness in the space of economic development and health in its broadest terms. So I'm very grateful to have them part of this discussion and have me share what I have for you today. So what I would like to talk about, as stated before, is the health professionals thinking outside of the hospital. And I'll just start a little bit with, before we start, just to give a background, NYIT College of Osteopathic Medicine, for those of you who may not know, is the first osteopathic school here in the state of Arkansas. Our primary mission here is to increase the physician workforce in the Delta and in Arkansas. We make it a very strong effort to recruit people from our neighborhood, from our communities, because data shows that they're most likely to stay here and practice care, give care to their community members. But we also have students from all over the country that come here and practice, and many of them able to win them over because they get a greater understanding of this community and the opportunities that they have to be a part of that transformative process. But what is important that I would like to share with everyone is that we are an institution, NYIT College of Osteopathic Medicine. We're an institution that really are aware that it's not enough to just train competent, compassionate physicians. It's not just enough for them to know how to care for the human body. You need a really good physician that's very competent and provides quality care. But many of our students, every one of our students will be physicians, will be in communities where automatically they'd be seen as a leader, but may not have specific leadership skills. That usually happens in the medical field. But we were committed to make sure that every student that comes through our institution gets leadership training, but not only in training and leadership, but to really get a better understanding that if you're not looking at the factors and the environment of your patient, you're not able to provide really good care. No matter how well you give medication, no matter how well you give great medical management, if the environment of your community members, if the environment of your patients are not healthy, those things that you do for your patients will be extremely limited. And so we thought that it was very important that they receive significant training in population health so that they're able to engage with those factors outside the clinical setting so that they'll be able to provide care. This document, this slide that you see here is something I show pretty frequently to my students, where if you were to look at one health indice, such as premature death, the major driver for premature death is not so much what happens in the clinic or what happens in a hospital. Healthcare really, as you see here, contributes to 10% of that. But it's actually what happens in the social environment of the patient, the behaviors of the patient, the genetics of the patient. I also like to share with my students that the lines that you see in between social environment and individual behavior and genetics, they're not really a solid line. I would say that they're perforated. They're a bit blurred because none of us act in a vacuum. None of our behaviors are done in a vacuum. We actually do things because we're influenced by our community. We're influenced by our culture. We're influenced by our environment. And our genetics, actually, the way our genes are expressed, are also affected by our environment as well. So I like to make people aware when we're talking about health in its broadest terms, you have to consider what's happening in folks' environments. You have to consider what's happening genetically and how their lived experiences affect their genetics over a period of time. That study is called epigenetics, and how their environment can affect their individual behavior, access to healthy food, walkable, safe communities. Those things can have a strong influence in the way that people act and can affect their health outcomes. And so that drives really the heart of this discussion. This is a very well-known slide I use from the Kaiser Family Foundation that basically highlights 6 main categories of what we call the social determinants of health. And the data shows time and time again that the overwhelming factors that drive health outcomes, again, are not what happens in the clinic, although it's important. You need good clinical care. You need access to good clinical care. You really do need to pay attention to economic stability or even economic mobility, neighborhood, physical environment, the housing, transportation, safety. When it comes to education, what about literacy and language, early childhood education, and food, access to food, community and social construct where you have social integration, community engagement. If there's discrimination in a community, that can affect individuals' livelihood and lived experiences. And then you have the healthcare systems. And we'll see here that you'll see here that this is where we have most of these health outcomes. So the shared definition, the working definition of social determinants of health are the conditions in the environments where people are born, live, learn, work, play, pray, worship, and age, and how all of these things affect your quality of life and your outcomes. So because of this reality, the NYIT College of Osteopathic Medicine established the Delta Population Health Institute. So we're a group of people and experts. We're committed to addressing these social factors of health by promoting cultural transformation and creating health equity and catalyzing thriving, prosperous rural communities in the Delta. When we talk about health disparities, the main reason why we're talking about health disparities, and health disparities is defined as differences in health outcomes between different groups of people. Because of this, and because what the data shows us, our school teaches a course called Population Health. The study of population health is the study of how the distribution of health outcomes are different amongst different groups of people. You can divide these categories by gender, by race, ethnicity. You can divide these groups by geography, rural, urban, etc. And when you look at these different groups of populations, there are determinants that influence the distribution of these of the health outcomes. And there are policies and interventions that affect these determinants. So when you look at what I showed you before, these determinants of health, economic stability, education, food, community, etc., there are policies in each one of these categories that are affecting the health outcomes of everyone that on this call, in your household and in your neighborhood. And some examples I like to show here is infant mortality. In 2017, there was a publication where there was a greater number of people who are Black, Indigenous people, Alaska Native, who have a higher number of infant mortality per 1,000 folks. If you were to adjust death rates per 100,000 people, you see a higher disease among Black, Hispanic, Asians, and Alaska Native Americans as well. And when you look at health disparities amongst rural and urban areas, there's a higher rate of premature death when you have rural counties with majority Black or Indigenous populations. And very, very, very clearly, we saw these disparities for COVID-19 as well, where we saw that there were disparities again amongst BIPOC populations in cases, hospitalizations, and deaths. So there were higher rates of each of those in individuals who are either Black, American, Indian, Alaska Natives, Hispanic, or Asian. But even if you were to remove ethnicity out to the side, there was a big divide versus rural and urban areas across the board. When I saw this headline in this article called Rural Health in the Rural Health Journal, I wasn't surprised. Many people weren't surprised. Half of rural residents were at high risk of serious illness due to COVID-19. This was creating a significant stress in hospitals. And the reason why we weren't surprised were because we knew that when you were to compare rural and urban areas and look at the policies and the infrastructure around economic stability, built environment, education, food, and social context and healthcare systems, there were disparities in these policies when you were to look at rural and urban divides as well. So we did anticipate to see that in COVID-19 because the disease of the virus affected those who had a higher prevalence of diabetes or chronic illnesses or who are older, which are the folks that are in the communities that we're speaking of in rural areas. This is a really interesting, helpful graph I like to show people, like how statistically can education affect your health? So the studies have shown that the higher level of education you are to attain, you're most likely to have greater opportunities for better health. For instance, with your level of educational attainment, your ability to be literate in health knowledge and problem solving when it deals to health tends to be a little bit higher. So your behaviors, such as diet and exercise, will also be able to be transformed by the knowledge of what you know, depending on the level of educational attainment. Now, this doesn't mean that you need a college degree to be healthy, but it does mean that if you were to look at the studies, those people with a higher level of educational attainment tend to be more aware and more health literate. And so they know more options about better decisions for their health. When you look at educational attainment for relation to work, depending on your educational attainment, it does determine what category of work that you can do and the income that you have. And based on your work and your employer, that determines your health insurance, the amount of sick leave you can have, your exposure to hazards and imbalance or control and demand. So there's a lot of studies that look at this association of health, of education and health attainment. The reason why I'm showing you this is that if we're going to be talking about health and health in rural areas, we have to consider what we can do in the space of educational attainment in terms of opportunities for folks to make that happen. What I like to show here is the economic vulnerability of households. And again, I'm giving you a very broad picture before I get into healthcare, because one of the challenges I have in the discussion with speaking with healthcare professionals is sometimes they can't see beyond the walls of the hospital and can't see beyond the walls of the clinic. And that's important. Someone has to do that. However, I'm trying to bring light to what's happening outside the hospital and the people, what's happening with folks out before they come into the hospital. Really cool study from JAMA, which is the Journal from the American Medical Association, that pulled a survey from the American Community Survey and analyzed about 3.2 million responses to see who were what they call, who had economic vulnerability within essential workers. It's a word that we, throughout the pandemic, heard very frequently in terms of folks who essentially, I'll give you the definition by the Department of Homeland Security. Essentially, these are occupations necessary to the continuity of functions that are critical to public health and safety. So these are the folks that, without their presence on the work field, in work, it affects the safety of the public, it affects the security of the public. And so this study showed that if you were out of all at the American Community Survey, 40% of these people in our communities were essential workers. This was the breakdown in their demographic. Now, if you remember the whole discussion around essential workers, these were the folks that were most likely concerned to be exposed to people with COVID-19, okay? And this is how this article determined and described economic vulnerability: low household income, uninsured, household presence of someone 65 years and older. Just imagine someone who, in the context of a pandemic, already is working but may have a low income. They are uninsured because their employer doesn't provide insurance, and they have someone in a household that has a high likelihood of having illness. And in their study, they showed that if you had more than one of these things, you were at the highest level of economic vulnerability. That means you were going to either probably lose a home, not able to feed your family, probably lose your transportation. And these people were on the cusp really of losing everything. And we have to look at this factor when we talk about health and how hospitals may have an opportunity to engage with this segment of folks, and really in a broader sense, because besides the pandemic, anyone who is in these categories, it takes one medical disaster for them to be in trouble. And if you look at, again, the background of essential workers in the state of Arkansas, you have a group of people, this was a breakdown from the US Department of Commerce in 2020. When you look at the rural areas in Arkansas, we have a high group of people in farming and forestry, transportation, construction, manufacturing. Okay, so we have a high folks of people here in rural areas that are doing the jobs. They're deemed as essential workers, but many of them are in this economic vulnerability state, which is really important to note, which means they're like one medical catastrophe away from being, from not being able to care for their family in any way or becoming really ill. We remember during the COVID-19 pandemic, and as we're still going through it right now, there were some reports about meat and poultry processing facilities and how there were work areas. This was a workplace where you're not able to social distance. You're not able to maintain safety, or people who aren't able to take time off, leave. And this affected the health of the people, because eventually they got sick and people were able to come to work, and that affected the business's bottom line as well. So I just want to bring light to, the reason why I'm bringing light to this is the intersection of these factors outside the hospital. You have to look at economy, you have to look at education, you have to look at food security, and how we can transform the health of our communities, and then start exploring what healthcare professionals can do in this state. This really great article from Health Affairs that says, where health disparities begin is where the role of social and economic determinants are. That's why we have to look at policies, and current policies may be making it worse. And as many of you may remember, many businesses were looking at their own policies. They found that their policies came short to keeping people safe in the work environment, or be able to give sick leave and be able to, at the same time, keep the job running, or be able to pay people or stay above water when they're for their finances. So I'm going to narrow us down. That was the broad picture of what's happening outside of the clinic. I'm going to narrow us down to Arkansas, right? We know there's 3 million folks in Arkansas, about 41% live in rural regions. The rural regions are broken up in the Delta, the coastal plains, and the highland areas, okay? This is a map, and this was from the Bozeman Health Policy, the Public Health School at UAMS. It showed the breakdown of all the counties in the state of Arkansas. And the areas in the darkest green are the areas where there is the most sickest folks in terms of health indices. So the areas here in the green here in the Delta is the lowest part of the quartiles. Out of all the 75 counties, the area in the Delta is where we have the most challenges when it comes to health. And we see that because there's more poverty here in rural areas under the age of 18. As you can see here, the blue represents Delta. The rural area, this is the area for rural here. For children under 18 is blue, so we have a high number. We also see that there is employment divide between rural and urban areas. The highest level of employment here is in urban. The Delta here is right at pace here with the highlands, and then the coastal plains, that southeast part of Arkansas is a little bit lower. The poverty rate, the higher, the darkest hue of blue here represents the poverty rate as of 2018. And just remember that I did show you the map of health outcomes, that those counties that are dark green for health outcomes are also dark blue for poverty here as well. So we have to think about that association. Here again, you see the same similar pattern for food insecurity as of 2018. Educational attainment, in this study, in the US Census Bureau, they divided the rural, urban, coastal plains, and the Delta region. And the highest level is in high school, but when it comes to associate's, bachelor's degrees, it's much lower in the Delta region. Infrastructure, 40% in the area of folks may not have high-speed internet. And then there's been multiple concerns in terms of drinking violations since 2018 in terms of our water infrastructure. And again, I'm bringing us back to our map. When we look at these social determinants of health and we look at the health outcomes, you can't deny that there is some type of association, and we have to start looking at built environment, education, food, and social constructs. So what can we do as healthcare professionals? Now, the first thing that I want to acknowledge is We know what's happening in our rural hospitals, the threat of closure, staffing, beds, keeping healthcare professionals in the regions to provide care. These challenges are here, they are significant, and I don't want to undermine that or belittle those things at all. And it's hard for people who are just trying, institutions that are just trying to make it, to say, well, now I'm going to take care of go outside the hospital and start taking care of the poor or going into housing, et cetera. We're not saying that. That's not what I'm proposing. What I'm proposing is that even in constraints, there are perhaps opportunities such as convening power to bring people in your community together, to start thinking critically about how can we bring food security folks into the picture, housing folks into the picture, transportation folks in the picture, and invest in our community that way, so that not only are we focusing about people in the hospital being well, what can we do to keep people outside from even coming into the hospital? And so I just wanted to show you some examples, so you just don't think I'm just throwing stuff out here. But there have been a few rural hospitals that have been able, and this was a really good article that I'll be more than happy to share with everyone, that just came out this year. It's called Rural Health Professionals Thinking Outside the Box. And they did like a brief case study on a few health hospitals, rural hospitals in different parts of the countries that have started to make investments in the social determinants of health. And one is in the Northeast Vermont Regional Hospital. This was a 25-bed hospital in East Vermont. This is Northeast. What they did was use their community needs health assessment. Every hospital, every 3 years, have to do, by law, by the Affordable Care Act, have to do a community needs health assessment. And when this hospital did their community health assessment, they began to see those needs in food security, housing, transportation, et cetera. What this hospital decided to do was bring the leaders from each of these determinants of health and chose 1 or 2 problems, just 1 or 2 problems. And they said, if I can convene these folks around 2 problems, and theirs were around aging, alcohol, and drug rehabilitation, they were able to invest in entities through the hospital, entities to help people get out the hospital, keep them coming from the hospital, or supporting people in their homes through these initiatives. And not only that, you can't just have these initiatives, you need funding, that's acknowledged, but you also need policy changes. And they were able to use Medicaid funding to support these initiatives. The rural Wisconsin, another example is the Rural Wisconsin Health Cooperative. And I wanted to highlight this hospital because one of the things that stood out to me was the posture of leadership. And one of the quotes for the director, for Mary Berry's, when a director for this cooperative said is, rural hospitals can only be as economically healthy as their rural community. And so this person just shifted thinking about their hospital and expanded the view of into their community and the economy, the economic health of their community, and said, our hospital can't be healthier. It's not possible our hospital be healthier than the economy. There has to be a partnership and collaboration. And so the leadership is so important, just to have that awareness. Another quote she said is, we're trying to get statewide economic development leaders thinking about healthcare and get healthcare leaders thinking about economic development. Because each of those entities and more have some assets they can leverage to create some initiatives to address the issues that we're talking about. One example is that they created something, they created in their town a tax increment finance district so that they would have the government put money in the front end to help support expand broadband internet access. They also use their resources to analyze data to help hospitals develop their strategies to address some of these issues as well. And the last example I want to show you is the Kansas Hospital. They tackled the social determinants of health. So they created this funding to build a coalition. They had funding, whether it's through a foundation that they recruited, get funding from, to create a coalition to address active and healthy lifestyles and work site wellness initiatives, which was very powerful, working with employers to create healthy employees. They opened a clinic in front of their Tyson Food campus. They work with pregnant women to enable healthy births. And because of this, they were able to decrease non-emergent department use by 88%. The last thing I'm going to leave you is a framework that's been around since the 1970s called Health in All Policies. If you're ready to talk about how you can do some of these initiatives, this is a great framework. You can pull it off online. It's a PDF. to start bringing different collaborators from different sectors to talk about what issues you're facing in communities and what initiatives you can tackle based on this framework for health policies. It's been used by the World Health Organization around the globe and locally across in the country and locally. And it really focuses on non-traditional health partners to help address social determinants of health. You address health equity, you support intersectoral collaboration. There's multiple benefits for partners. Economic folks are getting pluses on their bottom lines. You're engaging multiple stakeholders, and it's a really collaborative way to achieve your goal. Thank you so much for your time. If you have any questions, please let me know.
That was great. Thank you so much. And do you have time for a couple of questions? Okay. If anyone has a question, go ahead and put it in chat. I do have one, and that is if you were giving advice to a community leader, out of all the things that you just discussed, what should be the #1 priority of theirs to have a positive impact on health outcomes?
Well, the first thing is I'm going to make reference to if we're at the intersection of health here, the hospitals have something called the Community Health Needs Assessment. And this is assessment that's done every 3 years, and it basically assesses the needs of the community that touches all those determinants of health that I talked about. If you as a community can come together and identify the 1 or 2 things that you can leverage your assets to help achieve, do that. And the other thing too is sometimes we don't have the right folks at the table. Sometimes we're leaving people out of the conversation. Have patient representation at the table, have patients and people who represent the community that they're, so from every gender, race, background at the table as well, different demographics, geography to help address the issue. So start with the problem and bring different sectors at the table. Don't only have one sector at the table, bring multiple people together for that. And that's the first place to start.
Oh, very good. That's great advice. Okay, I am not seeing, I guess you explained everything really well. I'm not seeing any more questions for you. I know you're a busy person, so we'll let you get back to teaching and researching and everything else that you do. But thank you so much.
Thank you so much for this opportunity. I appreciate it. Take care.
And so up next, we have Christina Wade, the Health Programs Manager for the Delta Regional Authority, and she'll be sharing information about the Innovative Readiness Training Program, which is a joint initiative with the Delta Regional Authority and the U.S. Department of Defense to bring free medical, dental, and optical care to Delta residents. Christine oversees DRA health programs, including Delta Doctors, Innovative Readiness Training, and Delta Region Community Health Systems Development Program. She's a graduate of the Delta Leadership Institute, we couldn't leave that out, and Harvard University's Executive Leadership Academy. She's also a yoga instructor, and no, that was not a part of her official bio. But Christina, thank you so much for being with us today, and I will let you get started with your presentation.
Thank you, Andrea. Just wanted to come on and share a little bit of information with you about the agency and the Innovative Readiness Training Program. So I am going to share my screen with you. Hopefully this goes well. Great. Can you see that clearly, Andrea?
Yes, yes.
Wonderful. So DRA was established by Congress in 2000. We make strategic investments in basic public infrastructure, transportation infrastructure, workforce training, and small business development. The agency also supports economic development through increasing access to quality health care. We believe that health is an economic engine and ultimately will drive future economic growth. So health in the Delta, in our region, a little bit about our region. We serve 252 counties and parishes throughout 8 states. And we are led by a federal co-chairperson, an ultra-federal co-chairperson, and the governors of these 8 states. So we have Alabama, Arkansas, Illinois, Kentucky, Louisiana, Mississippi, Missouri, and Tennessee. So in our footprint, 241 of 252 counties and parishes that we serve are designated as health professional shortage areas. And 244 of the 252 counties and parishes that we served are medically underserved. So we really are committed to promoting a healthy Delta. And one of the ways that we do that is through the Innovative Readiness Training Program. So in partnership with the Department of Defense and the U.S. Military's Reserve Forces, DRA supports IRTs in Delta communities each year to bring medical, dental, and vision services to residents at no cost to the patient. So the IRT program improves military readiness by providing these trained military doctors with in-field emergency response training while offering quality health care to residents, again, at no cost to them. So IRTs are exclusive to the US. They provide the key services that I just listed with, of course, lasting benefits to residents in our communities, delivers joint training opportunities to increase deployment readiness, and IRTs were authorized in 1992 in response to the Rebuild America initiative. So DRA has been hosting IRT missions since 2009. We have hosted missions in each of the 8 states that we cover. And last year, actually this summer, 2021, we hosted the Delta Wellness Mission. It was a tri-state mission in Lake Village, Arkansas, Lake Providence, Louisiana, and Greenville, Mississippi. Military personnel offer dental exams, fillings, extractions, vision exams. They fabricated eyeglasses on site. They provided basic medical services, nutrition and wellness consultations, physical therapy, access to local resources, and of course, continuity of care, which is essential to the mission because after the military leaves, we want to make sure that residents are able to access the local care that they need for all of their follow-up appointments. So a little bit about some of the missions that we've hosted again this year, the Delta Wellness Mission. Military medical members had 2,585 patient visits. Over 1,300 pairs of glasses were manufactured with a value of over $890,000 to the residents. A look at 2018, Alabama Wellness and Southern Care Wellness in Illinois. You see the numbers there, 1,066 teeth extracted and 809 pairs of glasses distributed. If we keep going here, this was a huge mission in 2017, where the military saw 25,600 patients and over 3,600 glasses were fabricated. So some of the benefits to service members, I'll just point out a couple here. 90% of service members reported having gained job satisfaction after being part of the IRT mission. 85% of those had not worked with joint forces. So on these missions, you'll have folks from the active Army or maybe the Army Reserve. Some are in the Air Force, some are in the Air Force Reserve. So you have multiple military branches coming together to serve the residents in our communities. So I thought it would be a good idea to walk you through the process of a mission. And I, we just walked through the Delta Wellness Mission. It was conducted most recently, again, in Greenville, Mississippi, Lake Village, Arkansas, and Lake Providence, Louisiana. So sort of a timeline here. Back in September of 2018, DRA considered 3 sites. We wanted to host a tri-state mission. And we submitted that request the following year in 2019 to the Department of Defense, and we were awarded the mission in July 2020. The only difference now is we want to engage a little bit differently with the communities that we'd like to assist. So we have created a notice of intent to apply, where if communities are interested in hosting innovative readiness trainings in their cities, they can go to our website and submit a notice of intent to apply, kind of tell us a little bit about what they'd like to see, where the missions will be held. We just want to make sure that we have the capacity to deliver the mission and also provide enough resources after the mission to residents. So the following month, August 2020, we notified city officials we were awarded this mission, and that's really when the work begins. The military will come, we create with the community a planning schedule, pre-site surveys at all of the clinic sites. we hosted these sites in the schools. So they came down, they took a look at the Greenville High School, they did a walkthrough, made sure there was enough room to sleep, made sure the kitchen equipment worked properly, made sure that traffic flow would flow properly. So lots and lots of planning, lots of calls, lots of working with the community on these missions. So in November, they come back out, and this is usually the schedule for the missions. In November, they come back out, they meet with the community, they meet with the local hospital, want to make sure we have a hospital or health department that would help us with bio waste disposal. You know, with dental services, you'll have gauze. Of course, we just can't put those in the trash. So we have to have a hospital typically will come by after each day or every other day to pick up biohazard waste. So just working out some of the kinks of the mission. There's kind of a time span between November and March where we plan and work with the community. And then the military will come back out in March and they will do another walkthrough, make sure everything's okay, just preparing for the mission that happened in July. So the one thing that was different about the mission this year is that the military had to work with the community to develop a COVID plan. We were concerned about, of course, we were concerned about COVID. They were concerned about COVID, but we didn't want to cancel the mission. So they worked diligently to put together a COVID-19 risk mitigation plan for the mission. So some basic things when residents came in, there was a temperature check and of course this verbal questionnaire, how are you feeling today? Have you had a fever? Same case for the military. Each day they had their temperature checked and they had to complete a daily questionnaire. They were required to, the patients and the military medical personnel, they were required to wear face masks. In the waiting room, we were socially distanced and there was hand sanitizer at the entry points and at the exit points. There one dental chair per patient room. The optometry chairs were 6 feet apart. Daily cleaning and admission. When the mission was over, there was a terminal cleaning of each of the schools, which means that they cleaned the schools from top to bottom. And of course, when the military comes, when they come, they sleep in the school building, in the classroom. So the cots have to be 6 feet apart, head to toe sleeping. A curfew was imposed because we just wanted to kind of mitigate the spread of COVID. So at a certain time period, military personnel would be, back in the school building. Here's kind of a basic overview of what patient flow will look like. This is a floor plan of the school. So, in red, you'll have where the military quarters. In green, you'll see where the clinic actually happens. So there will be a section for the dental, a section for the vision, and a section for basic medical care, as well as a pharmacy. They had a room designated where they sterilized the equipment. So everything takes a lot of planning. It's a pretty long planning process. And just, lastly, I wanted to reiterate this COVID-19 risk assessment plan. They evaluated every activity that could occur during the mission. They identified the hazard, they rated the hazard, and then they identified some risk mitigation controls. They re-rated the activity. So this is such a value to the community. We did not want to have to, cancel the mission. So they went through every activity to ensure that we would all be safe. They typically use the school buildings, as I've said. They use that kitchen. They bring their own cooking staff. So they had to identify all of the hazards that kind of go along with feeding 95 to 100 military personnel that will be on site. So no shared serving utensils, disposable cups, and things of that nature. Sorry. Excuse me. So we went through this COVID-19 risk assessment plan. We had to present to the school board And we had to make sure that everyone was comfortable during the pandemic with the military being on the ground. So again, very successful mission. The military was able to, which is important to them. They're coming here to train. So they were able to exceed their training hours. And of course, the benefit to our community, as you'll see, over 2,500 patient visits. So that is in a nutshell, the Innovative Readiness Training Program. Wanted to just see if anyone had any questions about the process or just anything about the mission that you would like to ask.
And you can feel free to unmute yourself or put a question into chat, whatever works best for you. And Christina, that was very well laid out. I appreciate you doing that. And so what questions do we have? Do you have a favorite story from one of the IRT missions you participated in, Christina?
There is a story that we'd like to share about a gentleman who came in with a toothache at a mission and just was not able to get dental care. Dental care is pretty expensive. If you do not have insurance, sometimes it's just difficult to get dental care. He came to the mission with a toothache. Of course, they did x-rays and they saw that the cavity had went through his skull, and they had to call, of course, the EMT emergency services, and he was flown out. And we saved a life during that mission. So, you know, usually something like that happens at every mission. Even if someone comes in, their blood pressure is extremely high, we usually work with a local hospital. They'll be set up in a resource center just to share information. And we have to go over there and tap them and say, hey, you know, I think this person needs to be seen. So we always appreciate the value of the mission when those instances occur, even more, because we are literally saving lives.
Yes, you are. And so same likewise, but what can go wrong? What are some situations you've seen where things have just gone haywire and you've had to react quickly to try to put it back together?
We had a mission where the air conditioning went out in the waiting room. We had to set up outside, and the inflatable waiting room collapsed. So you kind of have to think on your feet. You have to have more than one clinic location identified just in case something like that happens. We've had instances where we've submitted an application and maybe a school district has pulled out and say, hey, we decided we don't want to do this. Well, the thing is, this is a 2-year process, and the military has spent hundreds of hours planning for this. So we kind of have to scurry to either find another site or we'll have to eliminate a site. And that is why we do so much work on the front end to make sure, you know, is the community committed? Do they want this here? It's very important to take care of all of those things on the front end.
Okay, I have another question that's come through chat. What are best practices in working communities to share the resources of the DRA's missions in advance of the event?
What we have tried to do, we revamped actually the application process. Before, we would just kind of word of mouth, work with the community. Would you like to host a mission? Or if you're in the network, they would reach out to us. But right now we work with our communications department to really put the word out that, hey, submit a notice of intent to apply. You can submit that notice of intent to apply at any point during the year to submit an application for an IRT. So more so than word of mouth, we really tried to formalize the process. We've engaged our Delta Leadership Institute, our partners at ASU, because this program is not well known. We'd like to see more applications. So if anyone wants to reach out to me personally, reach out to Andrea, she'd let me know. It's more than welcome to answer any questions.
Okay, still have some more coming through. Does DRA or DOD help connect patients to follow-up care, or do they check on patients after they received care?
I mentioned earlier in the presentation continuity of care. During every mission, we have a resource center. We don't move forward with these missions unless we have letters of support and actual support from the health department and also the local hospitals and clinics. So in that resource center each day, there will be someone there, a point of contact where patients are given resources. Hey, the health departments offer this, the local clinics offer this. So there's always on site kind of a connection to the community. And in the application, we have to ensure that patients will be provided with resources for aftercare for every mission. So yes, that's very important to us.
Okay, and I don't know if you have an answer on this one or not, but does the Department of Defense have innovative readiness training in areas outside of healthcare?
They do. Construction, which we would love to be able to submit an application for. Construction, cybersecurity, vector, those are the three that I am aware of. We have only submitted applications for the health missions here at DRA.
Okay, great. So I have a question from a Leslie Durham of Louisiana, and I just had to say her name because Leslie, we're glad to have you on here today. But how do the communities react to the military?
They welcome the military. I can tell you that some communities during every mission, you'll have them wanting to cook food and provide lunches to the military. Some of the communities plan, we co-partner with an agency on an IRT, and there happened to be a rodeo in town. So after hours, after the clinic is over, they invited the military to the rodeo. They had free tickets. It's just a wonderful benefit to the community. The communities always welcome the military with open arms.
Good job. Okay. Lots of questions here. This is good. What is needed to take the missions to the next level?
Well, we have worked with the military just this past year. We kind of want to make sure we are addressing their needs. And of course, they want the training hours. They need their troops to be ready if they're deployed. So for them, they would like to increase the size and the scope of the mission. For the military, that's taking it to the next level. And for DRA, I believe that an improvement in the continuity of care would just elevate these missions. And each year we work on a better connection with the community, even better than what we do now. That's our goal. And of course, on the military side, they always want to increase the size and the scope. So for instance, they offer medical, dental, vision services. We want to hone in on the behavioral health services. And they also offer vet services. So a mission that includes 3 cities that offers all 5 of these services would be great for them. And for us, the continuity of care piece, because of course, when the military leaves, we still have our residents here that need the continued care. So.
Very good. Oh, well, we did have another one. Do you provide transportation to people to the site where care is being given for those that do not have access to transportation? It's a good question.
Yes, so DRA is the applicant, and the entity that submits the notice of intent to apply is the lead community partner. And one of the responsibilities of the lead community partner, if that is a need in that community, we work together to address that. So that providing transportation would be something that the community would lead on the ground.
That's very good. And I think that may be all that we have today as far as questions, Christina, but we sure appreciate you taking the time to be with us today and go over these things, and hopefully we can get some more applications out of Arkansas and even Louisiana, since we have some from Louisiana joining us. And so we are going to take about a 5-minute break, and then if everyone would like to come back, we'll get started with our next presenter. Thanks again, Christina. Appreciate you.
Thank you. Thanks for having me.
All right, I hope we have everyone join us back after the break. Our last but certainly not least presenter for today is Dr. Darren Summer. He's the CEO of Innovator Health and Assistant Professor of Clinical Medicine at the New York Institute of Technology College of Osteopathic Medicine at Arkansas State University. That is a mouthful. Dr. Summer's company, Innovator Health, is a healthcare technology company that provides simple yet personal telemedicine technology focused on bridging the healthcare gaps for medically underserved communities. Summer's work with NYT includes the creation of the first telemedicine training program for first and second year medical students. Previous positions include service as a physician with the U.S. Army's 82nd Airborne Division, serving as both the brigade surgeon and flight surgeon. In addition, his military career spans more than 20 years of service, completing 2 combat deployments and earning numerous decorations, including the Bronze Star, Combat Medic Badge, and the Combat Action Badge. After completing his active duty service, Summer went on to serve as medical director of the hospitalist program at Southeastern Regional Medical Center in Lumberton, North Carolina. He later was the senior vice president of hospitalist services with Premier Physician Services in Dayton, Ohio. Wow, thank you for your service, Dr. Summer. We appreciate you being with us today. I also had to put in a plug for A-State Innovate, as Dr. Summer used to lease space at the garage at A-State Innovate. And so we're really pleased to have you here with us today, and I'll turn it over to you.
Well, thank you all very much. It's great to be here. I appreciate the kind introduction. All right, so let me share my screen. I'm good to share, right?
Yes.
I got you. All right, here we go. I cannot fail sharing the screen if I'm a technology guy, right?
That's right.
So much pressure. All right, well, thanks. Oh, let me, bear with me just a second. All right, well, it kind of started on its own. So, well, thank you for the introduction. I'm an internal medicine physician, as Andrea shared, and I've been in the field of telemedicine for about 15 years now, and got interested in the space after deploying to Afghanistan. I had spent just a short time there, coming right out of residency, excuse me, and after learning about a lot of third world diseases, but never getting the chance to see them in residency, and then all of a sudden being exposed to them, it was a really valuable opportunity to learn about these conditions and treat them with the help of colleagues from around the world. And then I came back home and was serving in one of the poorest areas in North Carolina and had some of the same challenges I did in Afghanistan, but did not have access to telemedicine. And it just really hit me that we really should be learning new ways to employ that here in the United States. And so ever since then, I've been on this journey trying to figure out how we can bring telemedicine to communities, but also bring it in a way that's personal. So it's very difficult to come on a platform such as this and have to talk to a patient or family member about end-of-life care, about the diagnosis of cancer or HIV or other really difficult issues. And so this has been a really nice opportunity to expand my role in the field of telemedicine, both as a practitioner and as an entrepreneur. And so I appreciate the opportunity to be with you all today. So as Andrea mentioned, I am the CEO of Innovator Health. We have a technology company and a physician services company. And so I come at it from a variety of angles, including teaching and practicing. And so pre-COVID, when we look at telemedicine, it was really, I will say, minimally used. I mean, we had a few niches for it. We had very heavy use in psychiatry, teleneurology, and emergency rooms. There was some companies popping up here and there that were providing low acuity, low touch telemedicine services. But when you looked at the overall market in 2018, there was about 7 million billings for telemedicine in the healthcare space in a country that did about 1 billion visits. And so it was a very, very small amount. And then if you look at the value propositions, kind of, where were we with the use of telemedicine in the beginning? It was probably more of a convenience, or there was really kind of lack of options. So somebody that was using telemedicine pre-COVID, they kind of knew what they had. They called the local telemedicine service. They told them their symptoms. They got an antibiotic called in. So they did not have to go to the emergency room. They did not have to go to their doctor's office. It was low acuity, low cost. So there was some convenience and some cost savings. And then there was the emergency room uses where patients were using telemedicine because they went into an emergency room and they were sick, maybe with a stroke, and they needed help. But it wasn't sought after. It wasn't on the forefront of most patients' intentions to use telemedicine. And it was a much different time back then. And so I think it's really important whenever we look at telemedicine, we look at the value propositions, either from the user's perspective or the deliverer's perspective, as a way to mirror up the use of telemedicine. So we now have COVID upon us, and suddenly everything changes. We recognize that we have a disease and a condition that we really know nothing about. People still have to receive healthcare services, so we're trying to minimize the impact of going to the physician's office and potentially exposing staff and other patients. And we have all of the same challenges that existed for telemedicine pre-COVID. And so the federal government recognized that this would be a really important time to reduce those barriers and really open up the use of telemedicine in almost every capacity, very different than what it was being done just a few months prior to that. And so there was just huge growth. So if you look at 2019, Medicare telemedicine visits averaged 14,000 per week. And then pre-COVID, and then 2020, to date, telemedicine visits are up about 1.7 million visits per week. So it's like a 6,500% increase. And so that was just a huge change for telemedicine. And so the federal government was really instrumental in reducing the requirements for telemedicine and allowing billing. They would allow treatments across state lines despite some pushback from states. And physicians kind of used whatever they could find to do telemedicine. And so the goal was to stop the spread, reduce risks to patients and caregivers, maintain patients' health and well-being by giving them access to the physicians for refills and other care, reduce overuse of emergency rooms and doctor's offices. So if a patient thought, oh, do I have COVID? They could talk to their provider and allow physicians to bill for it. So it allowed health systems and physician practices to maintain their revenue that they otherwise might not have been able to do without the telemedicine access. And so CMS really changed the rules quite a bit. They did not require physical diagnostic touch with stethoscopes, examination tools, vital signs, and a lot of confusion was in place around crossing state lines for telemedicine. And it really wasn't CMS saying, hey, it's okay for you if you live in Ohio to see patients in Florida. It was really saying that, hey, if you have a population of patients that you care for in Ohio and they're, let's say, on vacation, or they couldn't get back home to Ohio from Florida, you would still be allowed to see them, bill and collect for those services. And we've kind of been waiting for telemedicine, pullback from CMS, but it hasn't really happened to any extensive degree. I think as long as the emergency mandate's in place, we're going to be allowed to do that. But I suspect at some point here in the next few months or early in next year that we might see some pullback for telemedicine and some more restricted use and restricted billing. So we'll have to see. I'm a little concerned that we finally have physicians using it, they're adopting it, they're enjoying it to some extent as our patients. And if we stop using telemedicine, all of a sudden, physicians, may not be inclined to continue to spend the money on it, to invest resources into it, to continue to learn how to use it, because we've really come a long way in the adoption of telemedicine over the last, few months to a year. So I just want to talk briefly just about the different types of telemedicine. So we have the store and forward, we have the remote monitoring, and then we have the interactive telemedicine. And so for store and forward telemedicine, we're looking at, let's say dermatology is probably the best example. Patient has a particular lesion, there's a picture of it, it's sent off to a dermatologist who takes a look at the lesion at their convenience and then sends feedback back to maybe a primary care office or patient. Then we have remote monitoring, which is becoming very prevalent. The VA just announced a $1 billion investment in remote monitoring for veterans of the VA system. And so being able to monitor heart rhythms and vital signs and other things to ensure that patients are well cared for is another component of that. And then last is the interactive, right? So that's where a physician and a patient come together and they talk about their actual condition. There may be diagnostic capability with vital signs and diagnostics with stethoscopes, examination cameras. You might have an intensivist who's running a code from halfway around the world. So this is probably the more common use today of interactive telemedicine. And really, I think where CMS wanted to see us go. So interactive is not approved with any type of phone or fax. CMS was very particular about making sure that there was actual live communications taking place. They did relax the HIPAA rules around that. So they knew that physicians might be using non-HIPAA compliant platforms. So if you used Skype previous to COVID, that was not approved, but they would allow you to use Skype after COVID, even though it wasn't HIPAA compliant. If you wanted a HIPAA compliant form of Skype, you had to use Skype for Business. Many physicians used their electronic health records. And then CMS did some code expanding, allowing for more visits to take place through telemedicine. So what we learned from this experience is that we were really woefully unprepared. We had physicians trying to connect with patients around doing telemedicine encounters, and those patients did not have the capability to connect with the physicians. They might have had an app to download. They might not have had access to Wi-Fi. They might not have had a cell phone. And so it was very complicated for them to try to do telemedicine. And so physicians quite often got frustrated, patients got frustrated, and then they would just fall back to using telephones as opposed to actually using a video conferencing platform. And that was really kind of the limit for most telemedicine. Some of the telemedicine that actually could take place through these platforms did not have access to any type of diagnostic tools, no real-time vital signs. So if somebody really wasn't proactive pre-COVID, they were really scrambling to try to figure out a way to integrate some type of video conferencing solution to maintain their medical practices. And I kind of looked at it as somewhat of a dating situation. So pre-COVID, the healthcare marketplace and telemedicine were kind of dating. If there was interest in doing something, it was kind of, we'll try it. If it doesn't work, it's no big deal. we'll just put it off and try it again. We might set up a program through a grant, and then it may or may not work, which is not a big deal. We didn't really spend a lot of money on it, so we're okay if we try it and it doesn't really happen as well as we thought it might. There wasn't a lot of attention put into place, and then all of a sudden COVID hits, and now we're married to it, right? And we're in this kind of honeymoon phase where we're learning how to adopt telemedicine, learning how to use it, trying to figure out how it works best for us. And so we're kind of struggling to really make it work effectively. And now, though, we're stuck with it. We really can't go back to where we were before. We have to continue to adopt it and learn. And so it's kind of this tough phase for the healthcare system and telemedicine as we kind of learn each other's systems. And the hope is that we'll get to a point where after the honeymoon phase, we've really learned how to live and work together, where we can have telemedicine seamlessly integrated into the use of everyday telemedicine for our patients and our physicians, so that if and when we have a worsening of the pandemic or a new pandemic, we're now very comfortable about how to adopt it, how to integrate it, how to build it into scheduling, how to have patients use it from their homes or other locations so that it can be fully effective. So kind of from this point forward, it's now trying to figure out, okay, now that we know telemedicine's here and it works and we're getting more reimbursement, we've made investments in maybe software platforms, hardware platforms, what do we do, from here? Is it going to continue to grow, or is CMS going to pull back and then it's going to contract? Our provider is going to be like, I'm glad this is over. I don't want to use telemedicine anymore. And they're kind of just going to set it to the side, or are they going to expand its use? Are people going to double down on the value proposition for telemedicine and really reach out? So I think what's going to happen is if we look at the market in general, there's going to be a small percentage of health systems that are going to do this really, really well. And they're going to like what they're doing and they're going to expand. It's going to be part of their strategic plan. I think the vast majority of health systems are going to just kind of leave status quo. They're not really going to pursue it. They're not really going to set it back. It's there. And then I think a smaller percentage are going to really struggle with it. They're going to be very frustrated, and they're going to seek help from other people trying to figure out how to do it better. And I think a lot of this success and ongoing use of telemedicine is going to really be predicated on what CMS decides to do. I think if they continue to leave the funding in place it is now, then I think telemedicine is going to grow substantially. But if they pull back the funding and disincentivize the continued use, I think we're going to find that telemedicine will not be adopted to the extent that we really think it will be. And I think CMS further adopting telemedicine is really going to change the opportunity for companies to come out for a lot of home-based telemedicine systems. So you're starting to see some of that with like TytoCare is one example of a telemedicine-based home technology that's supposed to be an all-in-one, check your temperature, check your heart rate, check your blood pressure, and built-in stethoscopes and otoscopes so that further things can be managed and monitored from a vital signs perspective. So it's kind of what we thought COVID was going to be, and now what we're seeing. So I think for most of us in healthcare, we didn't know what to expect from COVID, but I think in general, we thought it was going to behave like other infectious diseases. Patients were going to get sick, God forbid, some were going to die. But those that lived through it, or those that got sick, were going to get better, and then that was going to be it. And the healthcare system would eventually get back to its kind of pre-COVID norms. But I think what we're starting to see now, and I think it's going to take a little more time to know for sure, is that COVID is really having a long-term effect on patients' health and well-being. And patients that get COVID that had underlying medical conditions, obesity, diabetes, high blood pressure, coronary disease, chronic kidney disease, are surviving their COVID infections, are now having all of these conditions at a much higher state of effect, where that patient that was a stable diabetic, a stable end-stage renal disease patient, a stable patient with coronary disease, are now finding that they're not as stable as they were pre-COVID. They are having more hospital admissions, and they are sicker than they were before, and they're utilizing the emergency room more. So we're now seeing patients that got sick during COVID coming back to the hospital for multiple issues that are complicated by their effect of COVID illness. And so now we may see are not only the variants, but also complications from earlier COVID diseases on these chronic illnesses, which means we're going to have higher volumes in our hospitals and greater effect on our healthcare workers, because COVID and its lingering effects may be here to stay. So what we're seeing is higher patient volumes in the emergency rooms and on the floor, which is complicating things quite a bit for those with health systems that are really trying to struggle. Patients who, ultimately were stable outpatients are now finding themselves necessary to have to go back to the hospital time and time again. We're seeing physician burnout, right? I mean, if you take a hospitalist such as myself, that's used to seeing, let's say, an average of 15 patients per day, and now all of a sudden we are having to see 17, 18, 19, 20 patients a day, really getting to the limit of what our capacity is. That's been a big struggle for a lot of physicians, and really making it very difficult for them to sustain their regular practices. And so physicians may retire sooner. They may have their own medical issues and not want to work those long hours or be exposed to those conditions. I think see a more a higher effect of physician shortages, where physicians are not going to be available, and other healthcare workers are not going to be available to the extent they were. So we now have less healthcare workers with more COVID patients. And I think that's really going to create a very big burden on our healthcare system going forward. So if we don't figure out how to implement telemedicine and bring resources that may be in higher availability in one community to a community that has higher demand, especially maybe in cyclical waves, we're going to have problems. And I think New York is a really good example that, is going to be able to watch this in real time. You're going to see those healthcare providers that are saying, hey, no, we don't want the COVID vaccine, regardless of how you feel about it. And that's going to have an impact while we have higher volumes of patients coming to the hospital and to the emergency room, and at the same time having more patients, less healthcare workers, and now we're really going to have some big problems. And this is going to have a lot of other effects on our already underlying chronic diseases. And so I think it's going to be a really interesting time in healthcare to try to figure out how we can offset some of these challenges, and interesting time to watch and see how we can use technology to offset some of these challenges. So I just was asked to talk about some of the challenges as it relates to COVID, but also what types of things are we seeing as a result of this with the use of telemedicine going forward. And so I think two really big things that are now coming out of the COVID crisis is hospital in the home and community paramedic. So hospital in the home is the idea that a patient goes to an emergency room and needs hospital level care, but there is a resource available at that particular hospital that allows the patient to be taken back to their home to receive that care in the home. And so that may mean that that patient is taken by ambulance back to their home, and a professionally trained caregiver stays in the home with that patient, delivers maybe IV antibiotics, breathing treatments, oxygen, and other clinical resources over a period of a few days for a relatively low acuity patient, so that a patient does not have to tie up a hospital bed that may be given to a patient that has a more complex condition. And so CMS has started to pilot these hospital in the home concepts, whether this is happening for a patient that's coming into an emergency room and then going back home, or a patient that is in the hospital that needs a few more days of hospital level care on the back end of their stay, but are now being discharged early with telemedicine as the foundation to allow ongoing care to be delivered with healthcare professionals in the home on the back end. And so this should decompress the telemedicine, this should decompress the bed shortage and the physician shortage and the healthcare worker shortage that we're going to be seeing by allowing care to be delivered in the home. And so this opens up a whole set of new opportunities and new challenges. I think you'll see a lot of businesses that will be created for home health monitoring, for caregivers in the home. And I think this will create potentially some competition where hospitals may go back to being what they were in the beginning. You know, back at the turn of the century, people in many communities looked at hospitals as a place where people went to die. And in our lifetime, we look at hospitals as a place for where we go when we're sick and want to get better. But if we start shifting care because of technology improvements to back into the home, then we may find that lower acuity patients are going into their home, getting better and staying there. And then the sickest population of patients are now going to the hospital, where likely just based on the complexity of illnesses, they'll be dying or getting very sick, staying for long periods of time. And hospitals are not going to be amenable to family visits and other things like they used to be. And so hospitals may really transition, and this effect may have a set of unintended consequences on hospitals if volumes suddenly shift back down, where all of a sudden hospitals that have built all of this infrastructure and we're now delivering care in the home are no longer able to sustain the high costs of running a hospital, and we might see a sudden shift. And so it's really unclear right now where we're going to be in the next 5 or 10 years. Are hospitals going to expand? Are we going to expand physician slots? Are we going to expand nursing slots and respiratory therapy and ultrasound, or for the hospital-based care, or are those going to shift into the home where we're going to have more home-based care? And all of this is being complemented by the concept of the community paramedic, which is the idea that when EMS is called, a paramedic with a telemedicine capability goes into the home, assesses the patient, identifies whether or not that patient needs to go to the emergency room and tie up a bed in an emergency room, or can they safely be taken care of in their home. And so the paramedic assesses their vital signs, maybe does an EKG, and then calls their medical director, likely an emergency room physician within their county or within their health system, discusses the case, identifies what the patient's likely clinical condition is, may even have the capability to do some baseline labs and identify whether or not the patient needs to go to the emergency room. If they don't, what type of care can be delivered in the home? Can there be follow-up care from somebody in the hospital in the home model? Can the patient get a prescription, maybe an IV before the paramedic leaves, and then stay in their home? And so there's a lot of exploration with the community paramedic, especially now that COVID has really set the tone of a much busier emergency room and much busier healthcare services. So I think these two are probably the most profound new concepts and models that I'm seeing, where telemedicine is really becoming a core part of the hospital in the home and community paramedic model, and something definitely to keep your eye on as all of this tends to evolve over time. So the next step is in reducing isolation. So how are we using telemedicine to reduce the isolation of patients, whether it's care in their home or in hospitals? And I think one of the biggest personal impacts I've seen for myself is just the lack of interpersonal interactions with patients. So, you know, if you've ever been hospitalized, or if you've ever had a family member hospitalized, you know how difficult it is to really stay connected with them, or with, if it was you, with your family or friends. Likely there's defined visiting hours, and this is pre-COVID, defined visiting hours. If you were in a higher level of care, like an ICU or PCU, you may not have allowed to have visitors at all. And then if you had any type of immune compromise, whether that was as a visitor or a patient, that likely further limited and isolated yourself. But hopefully that was somewhat offset by the fact that you had a personal relationship with the nursing staff and the physicians, and you could see them smile and you can interact, and they would hold your hand and touch you. And now all of a sudden COVID comes along and everybody's gowning up from top to bottom, right? They're wearing you know, space suits with full face shields and covering their mouth and wearing glasses. And so people are walking in the room and there is not that warmth, personal touch. There is not that smile. There is not that ability to have a normal conversation with somebody without having to try to hear them through a mask. And so patients are getting more depressed. Healthcare workers are getting more depressed because they are feeling more isolated from their peers and from their patients. And so how can we use telemedicine to really bridge that gap? And so I was sent to New York City during the initial COVID crisis with the US Army, and spent about 2.5 months at the Javits Center taking care of patients. And I brought one of my telemedicine systems with me, just with the anticipation that we could use it and identify ways to try to keep non-essential personnel outside of the necessity to go into where the sickest patients are. And so we didn't get a chance to use it in the beginning, but as things started to slow down, I was able to have a conversation with the leadership and say, hey, do you mind if we try to see how we can integrate telemedicine into this environment? And they said, sure. And so, you know, I was looking at it from a clinical perspective, but what we found most interestingly, what patients enjoyed about the most, was actually getting to see the caregivers smile and face when they dialed in. Because, you know, early on in COVID, many patients spent weeks in the hospital before they were well enough to leave the hospital and go to an acute bridge between home and the hospital, which was the Javits Center. And so when the screen lit up and they could actually see you smile, talk with you, and hear you, not through a muffled mask, they were really ecstatic about that. And that was fantastic. And so for me, it was a really amazing experience that, you know, I wanted to try to figure out, okay, well, how do we take that now? And now that we have telemedicine systems going in and out of these isolation rooms, how do we bring family members into this so that family members can interact with loved ones? And so a few weeks ago, I was taking care of a patient who was a World War II veteran. He was in his 90s. He went on active duty with the US Army back in the 40s. And his first duty assignment was at the Nuremberg trials in Germany. And he went on to serve in the Korean War, the Vietnam War, went in as a private and retired as a lieutenant colonel. He had an almost 30-year career and was just this amazing man. And we had these really nice conversations. And so I wanted to reach out to his family and let them know that, hey, you know, your dad, grandfather is in the hospital. Here's his condition. Here's what's going on. And so the picture on the right is his son all the way to the right, his daughter-in-law to the left, and their granddaughter on the screen. And what you really can't appreciate the picture, that particular screen that she's on is actually a 55-inch screen. And the sound system is a very nice, high quality sound system. And so she's broadcasting on an iPad that her brother had with them. and the family was together, just happened to be together. His son and daughter-in-law live in Texas. She lives in Colorado, and they were all together in Colorado visiting. And so we sent them a link to allow them to dial into the telemedicine system that we typically use to see patients, so that they could have an interaction, because the son said, hey, is it possible for us, should we head over and see dad in the hospital? And I said, you really can't, because he's in isolation. They're not going to let you in. And so they dialed in, and I wasn't sure what they were going to think or the patient was going to think, but they actually spent almost 3 hours on the screen together. They got to allow him to take his BiPAP mask off and eat and talk with them. And they just had this most amazing time together. And the son sent me a text message later that day and said, how much he thanked me for this opportunity. And I said, look, it means as much to me as it does to you. And then about 2 weeks later, we had to wind up transferring him to another hospital as he got sicker, and we were waiting on a bed. But they sent me a text message, and 2 weeks later he passed away. And they were on their way to the military cemetery in Dallas to bury him. But they really thanked me for the opportunity to have that. And I'm just thinking that, when you think about our traditional hospital rooms and a lot of larger urban-based health systems, they don't have telemedicine systems or even video systems in rooms that allow patients to have these virtual interactions. And I really think this is going to be an important part for us going forward post-COVID, or even while we're still in the midst of COVID, to start thinking about how we reduce the depression and isolation that patients face and allow patients and family members and caregivers to interact with each other, so that they can continue to have strength through these personal connections and not feel so isolated. I think it's important for our healthcare professionals, and I also think it's important for our patients. And so hopefully we'll find new ways of delivering those video connections and leverage the technology that exists in our hospitals to provide a more personalized level of care. And next, on the difference kind of post-COVID for telemedicine is the expansion of healthcare services. And so because of the work we did at the Javits Center in New York City, when Guam was having a real hard time managing a surge in COVID patients, the folks from HHS reached out to us and said, the team in Guam are having a hard time getting access to critical care. So Dr. Agon is the lady in the black scrubs, and she's the only critical care physician at the public hospital in Guam. And she worked every single day for about 2.5 months. And even when she finally got a day off and had a chance to decompress and go to Japan for a little vacation, she was still seeing patients by phone and talking with the hospitals by phone in order to make sure that people were well taken care of. And they tried to get help from the Navy, but the Navy didn't have access to electronic health record. And another limitation for the folks in Guam was that there's limitations in bandwidth, and the hospital really wasn't wired for telemedicine. So they reached out to us and asked us to help them provide critical care services, which we started doing in January. And it's interesting, and I wish I had the picture, but their initial foray into telemedicine was taking the base of an office chair that has, kind of the 5 spokes with the rolling wheels, putting an IV pole through the bolt hole at the bottom of the chair to make this mock telemedicine system, and an iPad stand. And that's what they were using initially to try to get some relief with some physicians who had previously been there on a support mission from the U.S. Army. And so because they had really taken this first step towards using telemedicine, seeing the value, they were very happy to start to see and expand services. So it began with critical care. We began providing critical care services. And then when they needed neonatology support, when there were 1 neonatologist left, we started providing neonatology services for them. Then we began providing hospital medicine services. In fact, I just finished my 12-hour shift providing hospital medicine for Guam's night coverage. And now we're looking at providing rheumatology. And so an expansion of services has really, I think, been one of the big wins for telemedicine, because now people are comfortable. Now they see the capability of what telemedicine can do. And so now they're looking at how we expand the services. So not how do we just put our finger in the dam, but now that we know and understand it, how do we expand it? And so Dr. DiGiovanni, the gentleman that you see there, is a rheumatologist. So in Guam, there's not a single rheumatologist on an island of 250,000 people. So there's a lot of undiagnosed rheumatological disorders. And if your rheumatology condition is bad enough, you're going to leave and have to go to Japan or California or Hawaii for your care, which is obviously very challenging for a lot of these rheumatological conditions that involve immune suppression and significant amounts of pain and other issues. And so what we're able to do is to be able to bring a doctor like Dr. DiGiovanni, who runs a fellowship program in Florida, and not only bring him in to provide rheumatological consults, but we're trying to find ways to bring his fellows in to expand access to the pathology that they get to see, but then also to provide care on the island. And so having the ability to provide new services has been really, I think, an instrumental part of the changes for the post-COVID era. And so the biggest services we're seeing are the pulmonary critical care, hospital medicine, infectious diseases, neonatology, and rheumatology. And so these are across multiple different hospitals, because pre-COVID, we had some primary care, we had neurology, which was a major service, psychiatry, and now we're starting to see some of the specialty services really expand and provide, this care. And so I think when you look at like a Dr. DiGiovanni, who is kind of coming towards the end of his career, he's super excited about the ability to take his experiences and continue to provide care. And even if he has, some healthcare challenges of his own, he still has the ability to stay in practice, even if he's not physically present there, to make a big difference. And so I think we're going to see a lot more expansion of services, specialty service, especially as you consider how healthcare is evolving. So, when you were a primary care physician or family practitioner, let's say 50 to 100 years ago, and you graduated from your medical school, you likely did not do a residency. Most physicians went into the community where they were going to practice and hung up the proverbial shingle and worked under the guidance of a more seasoned physician in their community. So that primary care physician was delivering babies, doing C-sections, maybe putting pacemakers back in the early days, and doing other procedures and care in these more isolated communities. But as healthcare evolves and as we become more dependent on specialists, we have almost 100 different specialties today. Not only are family practitioners less likely to have that broad of a practice today, a lot of them just don't want to. They want to work in the clinic or in the hospital, which means a small community-based hospital now has to try to either hire physicians to work just in the hospital, which is very expensive to do if they don't have the volumes. And compounded by that, any patient that needs a specialty service, whether that's just consultative or not, now likely has to send that patient from their emergency room or from their hospital to another facility at a cost to the patient, at a cost to the community, at a cost to the hospital. And so all of these have this domino effect where patients are like, look, if I have this chronic medical condition and I know I need a specialist that you don't have at your hospital, why am I going to go to your emergency room and then get transferred by ambulance to another facility only to have to pay for the ER cost, the ambulance cost, and then go to another emergency room? So patients are becoming savvy to this and they're bypassing it on their own, which isn't good for the hospitals. So if we can find new ways to bring telemedicine to these communities and keep patients local, keep a percentage of them there, that helps build a higher quality of care. It helps to improve the financial bottom line. And many of these patients are dependent on these hospitals, and many of these communities are dependent on these hospitals as well, because they typically are the largest employer And most companies don't want to go and build a factory or new businesses in communities that don't have access to good healthcare systems. So this domino effect has this really, really big effect over time. But if we can bring in physicians virtually, we can change that tide. And so as people become more comfortable with the capabilities of telemedicine, we're starting to see some of these changes. So I'm going to, so let me go ahead and stop here and answer any questions that you all might have.
I was fascinated, Dr. Summer, and anyone who has a question, you can feel free to unmute yourself and just ask, or you can place them in the chat. I did have one sent directly to me. Can hospital in a home be used to monitor COVID patients now in areas where there are not enough hospital beds?
Yes, and I think that's really what we're starting to see is, the patient that comes in that has some medical comorbidities, but they're not hypoxic enough to require remdesivir. We're trying to get them outpatient REGEN-COV, the antibody therapies. And I think those are the perfect opportunity to provide a patient with a home monitoring kit that allows them to monitor their oxygen level, their vital signs, their blood pressure. And so as we identify that those patients are becoming, more hypoxic, more tachycardic, having effects on blood pressure and other effects on their vital signs, we can intervene early, because what's happening is people don't want to go to the hospital. They think that if they go to the hospital, they're going to get sicker from other people around them that have COVID. And so they're waiting until they're so extraordinarily sick that we're finally getting a hold of them, but they're requiring mechanical ventilation potentially, or much higher doses of steroids. And so if we can integrate and start to bring these capabilities in the home sooner, we can likely prevent them from going to the hospital at all and intervene much sooner, which I think is going to be better for all of us.
Great, yeah, very good. Okay, can you give us an example of a surprising medical test or diagnosis that can be accomplished through telemedicine?
Okay, so ask me that question again.
An example of a surprising medical test or diagnosis that can be accomplished through telemedicine.
I can tell you a story, which I think will answer that question. So I had been asked to bring on some additional critical care capability in Guam, and I connected with a colleague of mine who is a dual boarded in anesthesia and critical care. And he was a little bit reluctant about the idea of actually being able to care for patients from his home in Texas all the way into Guam. And the very first patient he saw was a 24-year-old woman who had just delivered 2 days ago and had developed a cardiomyopathy and was on a ventilator. And the patient was very sick. And when she was born, her mom died shortly after birth. So it was probably some type of a congenital issue. And so Dr. Brady saw the patient, and because of his experience in managing specifically cardiac anesthesia issues, he was able to put the patient on an IV medication that was not commonly used. In fact, the nurse had never heard of it and didn't know how to dose it. He helped her with it. And the next day she was doing better. And a few days later, she was off the ventilator and moved out of the ICU. And I think it was as an amazing experience for him as the physician, as it was for the rest of the team. And it's those kinds of experiences that really change the paradigm and the idea of what we can do with telemedicine and how we can do certain things that we didn't think were possible just maybe a few months or a few years ago.
That is a good story. The next question is about, have you seen any declines of practices due to implementing telemedicine, specifically with regard to therapy, counseling, or visiting a psychologist?
No, I mean, I haven't. I think that most of my experience, when we integrate telemedicine, we start understanding and how to use it. We find additional efficiencies that make us more likely to adopt and continue to use it. And so I find kind of the opposite. So if somebody's experiencing challenges or issues by implementing a telemedicine program, I'd be very interested to learn more about that and to see specifically why and if there's ways to overcome that.
Yeah. Okay, it looks like we got one more. How can you accomplish good bedside manner through telemedicine? It seems hard. How do you put your patients at ease when you are interacting through a screen? And how do you teach this to medical students?
So that's an excellent question. And it's the whole focus behind why I started the technology company that I did. So when our physicians broadcast the patient's bedside, we do it on a 55-inch screen that's rotated in a portrait orientation. So I'm literally life size on the screen. And because of the way we broadcast with the camera, we actually have eye contact with the patient. And when we lean in or reach out, patients perceive a 3D effect as let's say the hand or the body gets closer to the camera, it gets larger. And so on a screen that size, it's perceived as being a 3D effect. And so you may or may not have appreciated that most of this talk I did by looking into the camera. And so you might perceive a more personal interaction. So a lot of what we teach the students is making sure that when we talk to our patients, we're looking into the camera, not at the screen. We take the self views away so people don't feel conscientious about it or have focus of video. We use much larger screens. We use much better audio, always making sure we use earbuds. Typically, when we interact with our patients, we have backgrounds. So we don't have anything in our backgrounds. It's just branded with the hospital logos. And so there's a lot of elements that we introduce to the students during the first and second year to understand how the video call is different than being at the bedside and how you need to overcome that through training. And we also put the students through the different roles. So the medical student historically in medical school learns from the perspective of the physician, but through telemedicine training, they also learn the perspective of the patient and of the nurse or the bedside caregiver that's supporting the physician at the distant site. So all of these different elements are involved in ensuring that the patient has a much better experience. And ultimately, there's no replacement for their being there physically, but there has to be some understanding that not every patient is going to have access to the care they need in the physical form, just as examples I gave you with rheumatology and some of the other services. But trying to enhance them in the most professional way possible is really what we try to do and what we try to teach.
That is interesting. I was trying to change my focus to looking into my camera when you said that, and that's really hard.
It is very hard. It's very hard. You get used to it though.
It makes you come across more trustworthy, and so I totally understand what you're saying.
Yeah, we very much underappreciate eye contact.
Mm-hmm. I'm not seeing any other questions in the chat. Anyone else have a question? Okay, if not, then I just want to say thank you so much for your time, Dr. Summer. This was very fascinating to learn about this and what may be the future of telemedicine and innovation technology, everything.
It just might be here to stay now. We will see.
We will see. I think it may be, and I think for rural areas, that's a good thing. They get the care that they need, and it would be good for economic development in the areas too. So thank you very much. And so to close,
appreciate being here.
You bet. And thanks everyone else for joining us today. Our next workshop is scheduled for October 7th. It'll be a much shorter day, but the content will be exceptional. It's Stoneward Advertising will lead an interactive session on communications during a crisis. So you can register on our website for the October 7th workshop, and Mary Margaret just put the link up into chat. So thank you all, and I hope you have a nice evening.
Driving through West Virginia, and I've seldom been thinner, with that chip on my shoulder. And this past year I got so much older.